vulnerable of progressing the dissection proximally. Now, how many days we wait? Usually we do another CT in approximately within the first week. And depends how the CT looks like, then we can do the stent. It's always a balance between placing a stent on uncomplicated dissection on somebody that does not have any malperfusion of the leg, kidney, or clinical or radiologic malperfusion. As well as we need to make sure that we do have a decent follow-up for these, patients. So within the week, we take a CAT scan, and depending on the situation, we place a stent graft or we just manage the patient with the medical, treatment. For the chronic ones, the chronic can be a little more challenging. On the chronic, the flap is not fragile and is not pliable, is not, something that remodels easily. And this is one of the, I think, issues right now with endovascular therapy. We do have all these nitinol plugs and the things that we're using, and I think, and the fracture of the septum, and different other things that I think Cleveland Clinic have actually shown well, and as well as others. But this is not like the real, solution. The current stents that we have now are not really designed for the chronic edematous phase. They've been designed for aneurysms, and they're approved, at least in the US, for the acute dissections. They're approved also for the chronic, but the original design was not for the chronic. So for the chronic, I don't think that we have really the solution. We do proceed with the endograft, especially for the high-risk case, as well as for the ones that they have anatomically are good for endovascular procedures.
Okay, one more question. Okay, Dr. Adefe from Port Harcourt has a question for you. Okay, go ahead. Dr. Adefe, go ahead. Dr. Adefe, are you there? We lost you. Dr. Adefe, are you there? I guess we can get him on. Okay, Ourania, thank you so much. I appreciate your help, and we'll be talking to you soon.
Absolutely. Thank you, Herbert. Thank you for being there. Thank you for supporting our chapter. Thank you for being our president of the International Society of Endovascular Specialists, the Africa chapter. And really, this is a tremendous effort. Thank you, and thank you everybody for being there, and please join us. And I'm really hoping that the next year to be able to be there in person. Enjoy the rest of the conference. Thank you so, so much.
Thank you, Ourania. Thank you so much.
Bye.
Our next speaker is Dr. Zichal. He'll be talking to us on TCAR. TCAR, transcarotid artery revascularization, and its benefits and its disadvantages compared to carotid endarterectomy. Dr. Zichal.
Hello, everyone. Hopefully this works this time.
Yes, sir. You're good.
All right. So I'm just going to talk about transcarotid artery stenting. You can just go to the next one. My name is Ernest Zichal. I'm a vascular surgeon. I do also endovascular surgery here in Newport News, Virginia. So always the rationale for a less invasive approach has kind of been the mainstream for us, doing open cases versus kind of moving now more towards an endovascular approach. Over the years, certainly the carotid endarterectomy has been the gold standard for decades now, and it's a great procedure. If you're going to make an incision, it's kind of tiny. Do we really need to improve upon this procedure since it works so well? You can go to the next slide. Next. Maybe not. But certainly some of the things that maybe we can potentially work on is the overall procedure time, the length of stay in the hospital, incision length, or where the actual incision was made. And certainly we kind of first started off going transfemoral. And what we've found, it's a less invasive procedure, but is it really more successful? And we found that transfemoral approach does lead to a higher risk of stroke during the operation, let alone some of that higher risk of stroke actually being in the ipsilateral side, or potentially even the contralateral side. TCAR is a little bit different because they've kind of found with transfemoral carotid artery stenting that the vast majority of the, as expected, there's also some atherosclerosis located in the aortic arch or in the inamen or the ostium of the common carotid arteries. And as a result, that's kind of where we're getting some of these additional potential strokes or pitfalls. And so what TCAR does is it kind of, skips this, the approach through the arch and goes right to the common carotid artery, and we deploy the stent that way. What they're finding is that the risk of stroke in CEA is about the same as it would be in a TCAR. You can go to the next slide. As I was kind of stating earlier, that we know that the arch is definitely the source of the stroke. We are getting certainly same-side strokes, about 4%, but you're also getting some of these strokes in the ipsilateral, which we know that as a result is probably more from the aortic arch really being the result, because you don't see typically any ipsilateral, contralateral strokes in an endarterectomy. You can go to the next slide. Here's another study where they kind of looked at the amount of hits that were being shown using diffusion-weighted MRIs. And they were playing, once again, you can see the transfemoral carotid artery stenting using the MOMA device, which I don't even think is being used anymore, which is a Medtronic device. Had a pretty high result, which is they were trying to use just flow stopping. Transfemoral is the highest, with even various filters or shields. We still end up getting some hits. But the TCAR, as well as the carotid endarterectomy, have a very low percentage at 17 and 18% respectively. Next slide. So this is kind of what this is. This is I'll show a little bit of more animation a little bit later, but this is kind of a quick glide of kind of what it looks like. You got a common carotid artery axis, then you have the contralateral femoral vein axis, and what you're doing and the way you protect the arch is, one, we avoid the arch, and then we do back bleeding through this special filter. And then since there's a difference in pressures, the flow is actually, you're doing flow reversal while you're deploying the stent. And there's a little button that you can push on the thing in order to prevent it from doing backflow. In order when you take your pictures, you can move to the next picture. Next slide. Next slide. Once again, post-approval study, transcarotid revascularization in patients is showing that we're looking at the long-term surveillance now. We're looking at symptomatic and even asymptomatic patients, because typically we're moving, when we're doing TCARs, they had to meet the certain criteria in order to meet the stent criteria, which was either had anatomy that wasn't favorable, had previous carotid endarterectomy, had radiation to the neck, or they just weren't sick enough. And when we look at now, they're starting to move into kind of some studies of where there's asymptomatic patients, and we can certainly see that the stroke rate is very similar between carotid endarterectomy and TCAR. You can move to the next one. So they've kind of gone, like I said, they were talking over long-term, kind of looking over the last centers and looking at overall, stroke, myocardial infarction, or death 30 days. and this is where they're comparing TCAR and carotid endarterectomy. You can go to the next slide. And obviously, over that time frame, TCAR is becoming more and more used. And once again, the endarterectomy and TCAR shows the same rate of myocardial infarction, stroke, and death rates, which shows it's just as comparable to CEA and is as safe. But there actually has been a little bit of a reduction in about 10% of people where they're doing the carotid interventions or they're doing TCAR over carotid endarterectomies. You can go to the next slide. This is another slide, kind of once again comparing carotid endarterectomies alone or institutions where they have TCAR and carotid endarterectomy. Certainly, they're seeing that there's a reduction with time where they're using the TCAR that is showing some better outcomes. Is this certainly potentially just from have more experienced surgeons doing more procedures versus is it actually the TCAR that's kind of improving this? Some of the data is suggesting that potentially that the TCAR might be improving kind of your overall MACE or myocardial infarction, stroke, and death outcomes. Next slide. So kind of charging the right procedure for the right patient. There's certainly trying to figure out, what is going to be the best going forward. Certainly is going to be probably maybe some debates in the future, whether it's TCAR first or just continue with carotid endarterectomy and using the TCAR for our patients. Next slide. So where and how to use TCAR? Certainly, as I was stating earlier, there is you have to at least qualify, or at least originally now, at least in the United States, they did make it so you can perform TCAR for not having to meet all these criteria. But still, this is kind of goes along with the stenting criteria, which is greater age than 75. They've had prior radiation or surgery in the neck, or they've had a previous carotid endarterectomy, or there might be contralateral occlusion or significant stenosis on the other side, or inability to actually access it through a carotid endarterectomy incision. There are some other things that you could use in order to get the criteria met in order to deploy the TCAR. But there are some actual requirements in order to be able to do it, of which you need to have a greater than 5 centimeter working distance between the clavicle and your bifurcation, and that's in order to get this sheath into the common carotid artery. And then certainly you have to have a common carotid artery that's big enough in order to accommodate that sheath. And you want to make sure that the common carotid artery also doesn't have a significant amount of disease, because otherwise you could potentially be placing off or causing distal embolizations with plaque. We can move to the next one. So protection from stroke and so much more. Certainly stroke and death, they are equal between carotid endarterectomy and TCAR. When it comes to myocardial infarction, there is a slightly less risk with the TCAR, the cranial nerve injury, which may or may not be typically it's not permanent, but certainly can be temporary. There is certainly, and that's probably where the biggest overall benefit is. You see less cranial nerve injuries. And the procedure itself usually probably takes maybe about 30 minutes less than if you do an endarterectomy from incision to a closure. Next. As I was stating a little bit earlier, the TCAR does typically take about 73 minutes, and the carotid, it's about 30 to maybe 50 minutes longer, which is always better, less time in the operating room. I think you can go to the next slide. Typically when we're doing these, you can use MAC. You can certainly use a local MAC with supraphysical black with a carotid endarterectomy, but it does seem to be a little bit easier with a TCAR. Next slide. Most of the patients, the pain is significantly less. They are certainly able to be discharged. It's usually pretty much about the same, but there might be a little bit of a less stay with TCARs. Next slide. Yep. We're talking about the procedure time. I said once again is usually about 33 minutes shorter, as well as I think it's on there, typical clamp time or flow reversal when it comes to the TCAR is usually averages around, I think, about 10 minutes, 10 to 12 minutes, versus the average clamp time is usually 30, 35 minutes for an endarterectomy, which is some of the things that you do in order to place the carotid stent is certainly needed to be on dual antiplatelet therapy, and certainly you want to make sure if they can tolerate statins to also be on that. Usually for most of the imaging, because you want to know the distance, a CTA or an MRI is usually what I go with. Depending on how good your ultrasound tech is, you can certainly have them do some measurements as well. But once again, it's usually very tech dependent. I know I've done some of my TCARs based off of my ultrasound tech, but I trust her compared to most of my other technicians. Next slide. Next slide. All right. There is a little bit of a learning curve, but the good thing is, no more than kind of what your statistical equivalence is the statistical outcomes of the procedure really do not matter too much. Certainly your times get faster anytime we do something more, we get more and more efficient. Flow time decreases expected, as well as complications. But there's been no major statistical difference between the level for the outcomes when it comes to your MACE. Next slide. And this is just kind of some of the newer data where they're looking at standard risk patients and looking at the 30-day stroke rate, which is equivalent at, as you can see, 2.6 and 2.9% between the cases. Next slide. And then once again, looking at the standard risks, as I was kind of saying earlier, certainly a stroke, death, myocardial are all equivalent. But where you do see that big difference is in the cranial nerve injury, which was found to be statistically different. It was 0.3% in TCAR and 2.7% in carotid endarterectomy. Next slide. Certainly clear advantages where you might want to do a carotid endarterectomy is obviously if there's a low bifurcation or that distance is less than 5 centimeters, or there's a significant amount of common carotid artery disease, or there's lesions that may seem more to be thrombotic than plaque buildup. Also, if the intracranial internal carotid artery diameter is greater than 9 millimeters, and that's simply because we don't have the stents that are going to be that big, or if there is less than 4 millimeters, because once again, trying to put a stent in that's going to be too small. Some advantages are there's a high bifurcation, hostile neck, it's a reoperative site, and if you just don't know if your patients can tolerate that type of procedure, or if they're not medically stable enough for a general anesthesia. Next case. Slide. Kind of all things being equal, why do we think maybe TCAR first? Incision location provides an easier arterial access. There's less time in the OR and there's less time under anesthesia. You can use local anesthesia more often. There's also tends to be maybe a little bit less bleeding risk. And then certainly as kind of proven is the biggest thing is the cranial nerve injury is less. Next slide. So how does it kind of perform? As you can see, we make what I like to do is I take the ultrasound and preoperatively kind of mark where the common carotid artery is, it's always right between those two heads of the sternocleidomastoid muscle. And then we make an incision. I'll use my ultrasound just kind of in order to make the length of my incision, and I'll numb that whole area up with lidocaine, make an incision, dissect out the common carotid artery. And then we also then want to get contralateral common femoral vein access, and so we put a sheath in that. Next slide. Let's see if it. While you're doing this, we want to make sure you have the vessel loops kind of prior to where you're going to do a needle access. I'll use a little purse string over the common carotid artery. And then I will stick a micropuncture needle in there and put a wire access. And the wires are marked out of how far you put the wire in. And then you put the microsheath. Then usually you would take a quick angiogram to confirm our location. And then you would deploy this special Silk Road sheath. You can go to the next slide. As you can see, it's coming in. The nice thing about the sheath, it is a little bit angled up. So once it goes in, it should directly, give you better access instead of, typical most sheaths just go straight in. It's got a little bit of like a hockey stick to the tip of it. Okay. You can see, all right. And then once that sheath is in, we then go ahead and hook it up to the machine. There's a video coming up too you can look at, and then you have the flow reversal, which is there, and then you hook it up to the femoral sheath. And then when you do tighten and you're getting ready to deploy and cross the lesion, you tighten the vessel loop that you placed before where your axis of the sheath is, and then you should have flow reversal. And then you can deploy the stent. Cross the wire typically takes, like I said, usually about 7 minutes. Next slide. And then we just kind of close the incision up. This is, hopefully this video works and goes over everything quickly. Shows you kind of like all steps. If it doesn't, hopefully I explained it well enough with the pictures. I guess it didn't. Sorry about that. Here's
Sorry,
just
the
a
video
patient.
won't work as it's a PDF.
Okay, that's fine. Hopefully the pictures were enough to kind of explain the procedure. Here's a case study. Here's a patient's 87-year-old male with history of hyperlipidemia, hypertension disorder. Quit smoking in the 90s. He's already on aspirin and Eliquis. And just to note, if they usually want to have dual antiplatelet therapy, if they're on dialysis, what we usually do is we stop the aspirin and then we would start the Plavix at that time and keep them on Plavix for about 30 days and then switch them back to aspirin along with their, and then they would start the Eliquis post-op day 1. Next slide. Here's his preoperative CAT scan. You can see he's got a contralateral lesion that's on duplex. It was kind of interesting because his duplex showed his right was 80 to 99 and the left was 70 to 79. However, in CTA of the neck, the right was only 70% and the left was 80 to 99, which is why we proceeded with doing a left TCAR. Next slide. This is his angiogram right prior to placing the stent, and then this is the stent after the TCAR placement and the lesion look like. Next slide. I think that was the last slide, but yep. So he's post-op discharge 1, and he had actually ended up having an endarterectomy on the other side about a year later. You guys have any questions?
Any
Dr. Emanuel?
Any questions for Dr. Zichal? Again, this is a TCAR procedure often uncommon now for the past few years, and compared to standard carotid endarterectomy. Any questions on this? My question to you, Dr. Zichal, would be, what do you do for short neck, deep artery that you think even standard open endarterectomy would be difficult? What is potential, or what are the options for TCAR?
So you can still kind of do a TCAR. It kind of you can do what's called a conduit. You might be familiar with that for the aneurysms, where you could maybe get through the common femoral, or you might sew on a iliac conduit in order to deploy the stents. So it's kind of the same premise where you can get down to the artery, and then you would sew on like a 6 millimeter PTFE or Dacron graft onto the common carotid artery, and then that gives you your extra length, and then you can kind of still deploy a TCAR that way. Certainly that does add length to the procedure. I've done that once, but also hopefully they could maybe undergo an endarterectomy at that time. And then you either remove the whole conduit, or sometimes you just leave a stump, of the graft.
So if I have to play devil's advocate, if you know you're going to do a conduit, why not do a standard carotid endarterectomy?
That would be the big question, correct? I mean, whether or not you think the patient can withstand a carotid endarterectomy, you can certainly do them awake. Some patients do have a lot more anxiety with the drapes being on their face. If they're claustrophobic, that might be an issue. But you could probably do a endarterectomy. Certainly, the data does support being able to do a TCAR now. But you probably should go with what do you think is the most comfortable for you to do, I would say.
One of the things that I see in my experience with TCAR, again, is postoperative hypotension, more so than you see with standard carotid endarterectomy. How do you manage that?
So that's a very good statement. I did forget to mention that. So typically, when you do a TCAR, most of the patients are going to be hypotensive. Usually, I used to write a PRN of Sudafed, and we give it about every 8 hours. I've now switched that to where I just give it automatically, because that seems to help a little bit. Certainly, if you do have to use some pressors, you might have to. That happens occasionally, because you do want to keep their pressures up. I've had one patient that did actually have hypertension, where you just kind of use, your typical antihypertensives, versus your open carotid endarterectomies. You do tend to typically have more of a hypertension issue versus a hypotensive.
One of the things that I do see also with TCAR, even though you have the hypertension, they're usually asymptomatic. Is that your experience?
Yeah, I have. Yeah, no one usually. You might have a little bit of bradycardia too, or at least less of a heart rate, but they're all very asymptomatic. But they have kind of found, or at least you do want to keep their blood pressure, their systolic at least above, or I always try to keep mine above at least 100. Um, but most of those patients are not complaining of anything, so it is very interesting.
So in the context of this conference, we do know that carotid endarterectomy is the gold standard for carotid surgery. Now, we don't have the complement of TCAR technology here at this time, so we would have to work with time and see how the technology is translated. At least that option is translated to this patient population here with time, and also think about a cost implication of new technology in a society that's not used to having such items like we commonly have in the US. So, well, thank you so much again, Dr. Zichal, for the opportunity to present to us today, and we thank you for your time.
Thank you very much. Thanks for having me, and hope to see you guys in the future.
Thank you so much. Okay. Next speaker would be Dr. Edefe. He has to talk for us from Nigeria, Port Harcourt. We'll be coming up shortly. And well, let's just have a working lunch. So just grab something to eat while you listen to the talk, so that way we can catch up on time. We have Dr. Palma coming in soon at 3 o'clock, so our time. So we want to make sure we have a track. So please get something to eat, and we'll just continue the talk. Dr. Edefe, you ready?
Yes,
Okay.
I am ready.
Oh, he's so excited. Okay, Dr. Manuel Edefe comes to us from Port Harcourt. He's a cardiologist, interventional cardiologist, who works out of Port Harcourt as well as the Bielsa Specialist Hospital. He is quite adept with endovascular work, and he is doing great work. Today, he'll be talking to us about a case study on SFO occlusion. Dr. Edefe. Thank you.
Yeah, thank you very much for the kind introduction, Dr. Ye. So let me just share my slides. I'm just seeing a way to share. Okay.
Beside the mic button is a square with an arrow. So when you click that, it should be prompted to share your screen. Dr. Edefe, you've muted yourself. Dr. Edefe, can you hear us? Right on the bottom where the camera icon is, there's a mic. If you could click that to unmute yourself, and then the box with the arrow for your screen sharing.
Can you see my slides?
Yes.
Okay. Perfect. Okay, yeah, Dr. Oye, thank you very much for the kind introduction. So again, this afternoon we'll be talking about SFA total occlusion. What are the endovascular options in Nigeria? So I have no conflict of interest to make known. So crossing and treating chronic total occlusion in the superficial femoral artery remain a significant challenge in the treatment of peripheral artery disease. Peripheral artery disease present as, yeah.
We're only seeing PowerPoint on the screen right now. Is there anything else we can do?
Okay,
Just
let me
advance your
stop sharing and reshare again.
Okay. No, okay.
Yeah. Can you see it now, sir?
Not quite. We'll just see. It's not open yet. Open it still. It's not open yet.
It's not open yet.
No.
Okay, let me stop sharing and reshare back.
You want us to go ahead and do another case while you're getting this ready? We can.
Yes, yes. Go into
Okay.
the next person so that I can sort out my
walk out your technical difficulties. Dr. Gupta, can you get Jennifer ready for us, please?
Yep, we are ready for Jennifer.
Okay. Okay, let's have Jennifer give a quick talk while Dr. Ed is working out his technical difficulties. Our next speaker is Jennifer Onyamaenu, and she is a third-year medical student who will be talking to us today on the case study presentation. Jennifer, are you ready? She's in Beckley, West Virginia. Go ahead.
Yes, I can hear you.
Okay. Good day, ladies and gentlemen. I'd like to thank Dr. Oye and the coordinators of this conference for the opportunity to stand here today and present. My name is Jennifer Onyamaenu, and I'm a fourth-year medical student at Avalon University School of Medicine. And today I'll be speaking on superior vena cava syndrome. What is superior vena cava syndrome? Superior vena cava syndrome is a group of clinical signs and symptoms resulting from the partial or complete obstruction of blood flow through the superior vena cava. The superior vena cava is formed by the junction of the left and right brachiocephalic veins. It is a thin walled vessel responsible for the draining of venous outflow from the head, upper extremity, and upper thorax into the right atrium. I've attached an anatomical picture of the superior vena cava, and we can see it right about up there. And then according to the Stanford and Doty classifications, there are 4 types of superior vena cava syndrome depending on the SVC obstruction. In type 1, there is an up to 90% stenosis of the superior vena cava with patency of the azygos vein. In type 2, there is a near to complete obstruction of about 90 to 99% of the SVC and still patency of the azygos vein, but an anterior grade flow. In type 3, there is also a 90 to 99% obstruction, but the flow in the azygos vein is retrograde. In type 4 obstruction, there is stenosis of the SVC and including 1 or more major cava tributaries and the azygos vein. Before the use of antibiotics, the most common causes of superior vena cava syndrome were syphilitic, thoracic, aortic aneurysms, resulting in compression of the SVC and thoracic cavity adenopathy caused by tuberculosis. The first case of superior vena cava was described by a Scottish physician, William Hunter, in 1757 in a patient with syphilitic aortitis. The causes of superior vena cava syndrome over the years has evolved with medicine, but approximately 78 to 85% of malignant SVC obstructions occur due to lung cancer. Non-small cell lung cancer is the most common cause of malignant SVC syndrome. The second most likely cause of superior vena cava syndrome is non-Hodgkin's lymphoma, which accounts for 10 to 15%. Small cell lung cancer accounts for 22% of all cases of malignant SVC syndrome. It is a centrally located cancer with a rapid growth and is 5 times more likely to occur than a non-cell small lung cancer. Other causes of superior vena cava syndrome are benign or non-malignant causes such as thrombosis or long-term use of antibiotics, IV catheters used for chemotherapy, hemodialysis, or pacemaker wires. Superior vena cava syndrome affects over 15,000 patients annually in the United States. The deaths with superior vena cava syndrome is uncommon. The life expectancy of patients with malignant SVC syndrome is less than 24 months, as the malignancy being the major predictor of survival. The symptoms of superior vena cava syndrome initially are facial edema, as you can see in the pictures attached. Some patients present with varicosities and distension of superficial veins as well. Other symptoms include coughing, like I said earlier, facial edema, some present with edema of the face, the neck, upper extremities and arms. Some patients experience shortness of breath, hoarseness of the voice, rapid breathing, feeling lightheaded or dizzy, pleura, and increased intracranial pressure. In rare cases, some patients experience Horner syndrome, cerebral edema, and upper extremity compromises due to edema of the larynx and the pharynx. And some patients also experience cyanosis as well. If the physician suspects SVC syndrome, the following tests that will be needed to confirm the diagnosis, like maybe a chest X-ray, CT scan of the chest, venography, MRI, or ultrasound. We had a rare case of superior vena cava syndrome due to SVC aneurysm and stenosis. We had a 74-year-old male who presented to the clinic with facial swelling and painful bilateral upper and lower extremities. He described the pain as an aching pain and rated it a 5 out of 10 on the pain scale. 6 months prior to his arrival at the clinic, he was admitted for pneumonia, and after being discharged, was put on Lasix for the edema. He complained of shortness of breath and denied any history of smoking. His pulse on the day of the visit was 144/68 with a pulse of 59. He has a past medical history of dementia, black lung disease, pneumonia, a history of blood clots, acute kidney injury, B12 deficiency, and he had chronic lymphocytic leukemia. Past surgical history of hernia repair, a broken nose repair, and a right horn ligament repair. Upon physical examination, there was tenderness of the upper and lower extremity, as well as notable facial and orbital edema. A venogram was scheduled to be done on the basis of suspicion of superior vena cava syndrome. A CT scan was done, which revealed subclavian lymph nodes, no axillary lymph nodes, and no pleural effusion. A venogram was scheduled, and routine CBC, CMP, and COVID testing were done. No notable allergies and no acute cardiac diseases. So the venogram of the right upper extremity was done using a bilateral angiogram, which was placed in the upper extremities with low osmolar contrast being given. There was blood flow through the cephalic, basilic, axillary, and subclavian veins bilaterally. The patient had flow also noted in the subclavian vein. The superior vena cava segment demonstrated what appeared to be web-like stenosis. He required more intervention, but given that the patient had a history of acute renal injury, the venogram of the subclavian artery will be done via the right internal jugular approach the next day. So I'll come back to the pictures. So superior vena cava syndrome was done through the right internal jugular approach. A microvenous needle was cannulated into the right internal jugular vein using real-time ultrasound. A 4 French sheet, which was upsized to a 7 and 10 sheet, was inserted to confirm the stenosis of the superior vena cava, and there was stenosis noted of about 80 to 85%. So right here, the microvenous needle was inserted, and we can see the stenosis around here. There was also a notable sacral aneurysms. Sacral aneurysms are usually rare, but in this case, we saw both sacral aneurysm of the SVC and stenosis of about 80 to 85%. So angioplasty needed to be performed. So angioplasty was done using a 12 by 40 Atlas balloon, using the 7 French sheet right here. You can see the balloon. And then post deployment was done using a 14 by 40 Illuminex stent via the 10 French sheet, and then a post-deployment angioplasty was performed with a 14 by 40 Atlas balloon. So at the end of the procedure, the patient tolerated the procedure well, and there were no complications. How is superior cava syndrome treated? The treatment of superior cava syndrome depends on the underlying cause of blockage or obstruction. If there is a blood clot in the superior cava and is linked to an implanted medical device, thrombolysis will be used to devise the clot or the medical device removed and replaced. The following treatments can be used for cancer-related superior cava syndrome, which is like radiotherapy, chemotherapy, and stent placement. What are the possible outcomes for patients who have superior cava syndrome? If the superior cava syndrome is not treated, it can lead to serious complications such as swelling in the closing of the breathing tube, cerebral edema, and blood clots can break loose and travel to the lungs or the brain. Outcomes of patients with SVC syndrome, like I said earlier, depends on the underlying cause of the SVC syndrome and how well they respond to treatment. Patients who do not respond to the radiation treatment, the survival is less than a year. Thank you very much, and this is the end of my presentation. Any questions?
Thank you, Jennifer. Nice job. You did a fantastic job so far. That's a nice topic on superior cava syndrome issue. That was a really interesting case. Didn't realize there was circular aneurysm associated with stenosis. That was found at the time of the procedure. Had about an 85% degree stenosis of the SVC. Then a lot of review. No. So that worked out well for the patient. The facial swelling disappeared and the upper extremity swelling got better. Thank you, Jennifer. Any other questions? This question, Jennifer, for you. Yes.
Well, it's more, my question is with malignant superior cava syndrome. Currently, is it better to radiate or to stent?
Jennifer, question for you. Did you get the question?
Yeah, he's asking if it's better to stent or not. It depends on how bad the stenosis is. What's the percent, I would say. And I think in most cases, most doctors just prefer to go with stenting because it just prevents any more complications from just happening. That's what I think. For maybe Dr. Oye has a different opinion.
Well, I agree with you. That's reasonable. Sometimes when you, if you can cross a lesion with the stent, you will get immediate relief. And that's a better choice. Yeah. Okay, very well. Any further questions? If not, we'll go ahead and catch up with time. In the interest of time, we'll have Dr. Adafe come on quickly if he's ready, because we have Dr. Shaw coming from New York soon. Dr. Gupta, who's next? Adafe, are you ready?
Dr. Adafe, yep.
Is he ready? Are you ready?
Dr. Adafe, are you there?
Yes, I am ready. So let me share my slides.
Are you sure you're ready, Dr. Adafe?
Yes, I think so.
Okay.
Let me share the slides. Okay. Can you see my slides now?
Not yet. Yeah. Oh, yeah.
Good. So
yes, we can.
You can see it. I can go like this.
Yes, go ahead.
Excellent. So my talk is on superficial femoral artery total occlusion. What are the endovascular options in Nigeria? I'm a lecturer with the University of Port Harcourt and also a honorary consultant to the University of Port Harcourt Teaching Hospital. So there's no conflict of interest. Crossing and treating chronic total occlusion in the superficial femoral artery remain a significant challenge in the treatment of peripheral artery disease. Peripheral artery disease presents as a spectrum from asymptomatic disease to critical limb ischemia and limb or tissue loss. Accordingly, I will approach this looking at the presentations and also discussing what are the options we have here and what are the challenges. But suffice it to know that SFA total occlusion is mainly from chronic total occlusion, either from severe peripheral artery disease or critical limb ischemia, or it may also result from acute limb ischemia, where you have clot extending from the lower part of the artery, that is the posterior or the anterior tibial artery, stand down into the popliteal and extending into the superficial femoral artery. Now, the first case is a 69-year-old male living with type 2 DM for 30 years. He's also hypertensive for 10 years and with dyslipidemia for about 8 years. He had peripheral angiography with common iliac arteries around 2006. There is associated history of, he has numbness, coldness of the feet, and with no history of ulcer on the leg. So the examination revealed that is an elderly man with obvious distress, not pale, aneteric nose. The weight was 82, height was 168 centimeter. The cardiovascular examination is known for systolic hypertension and also has S4. So when we took him in for the procedure, we find out that one, the distal part of the SFA was totally occluded. Hope you can see the slide. Let me go into slide show so that I will be able to play the images. Yeah, so this is the SFA, the distal SFA part of it. You can see it here, totally occluded at the distal part of the SFA. So what we did was, because the angio was taken from the contralateral limb, so what we did, we took another anterogate puncture so that we can have a better way of talking, because I have a long sheet. So I took a retrograde puncture on ipsilateral femora so that we'll be able to take our devices down and take an a balloon angioplasty of that limb. And this is the result of that balloon angioplasty. We use a mirror, 4 by 120, and dilates the entire length of that vessel. Yeah, hope it's playing. Yeah. So at the post dilatation, this is what we now notice, that most of the vessel distal to the popliteal got opened up, and this was the final flow post dilatation.
We're not seeing the images, Dr. Demede. We're not seeing the images. No. Static.
Wow.
Static.
Let me go out of
again.
Yeah, let me go out and take it again.
It's not flooded, is it?
Yes. Let me share again so that the image can appear.
Looks like you're having a lot of technical difficulties from Port Harcourt.
No, I think take another case so that I can sort it out. It's still giving some issue here.
Okay. Is Dr. Shadi available?
Take another case.
Okay, let's see what we can do for you. Dr. Gupta, is Dr. Shadi available?
No, but Dr. Demede just got here.
Hi, how are you?
Yeah, put the meeting on if you can, put him quickly so we can catch up, please.
Okay, we'll put him next.
Hey, how are you? Great. Thank you, guys.
Nice to meet you.
Likewise. Hello.
Hi, Dr. Demede. Dr. Demede comes to us from Beckley, West Virginia. He's an interventional cardiologist, and he'll be talking to us today on his assigned topic, when is PCI necessary?
Hello, how are you today?
Oh, well,
I hope you had a good time with the conference. Good,
Thank
good,
you.
good. Okay. When Dr. Hoya asked me about to present when is PCI needed, it's a big topic. And is it an indication, or is it when you don't do it, or is it when you really change to another alternative therapy? Those are lots of questions arises. So I didn't think it's going to be so deep. So I was looking for relevant document as recent as possible. And there is a recent guideline around December 2021, as good as it could get, by ACC, AHI, American Heart Association, American College of Cardiology, and the SCI, Society for Cardiovascular Intervention. They came up in a really very comprehensive, very latest guidelines. So let's just go into it as much as we can. How long do I have? All right.
15 minutes.
Okay. So I will try to be focused as much as possible. The slide is a lot, but all are very relevant. And you will have a chance, I hope, to get the slide for those people who are really interested to get in detail into it. So when we say when is PCI needed, PCI is usually the most important part. When it is really needed is when somebody comes with either unstable angina or non-ST elevation MI, and the old name called non-Q wave MI, or transmural MI, which is a STEMI. And in those situations, or in condition where patients are stable ischemic heart breathers, but they failed medical therapy, then they may be indicated. So what are the alternatives to PCI? Coronary artery bypass surgery is one. The other one is guideline mandated optimal therapy. That's the second one. And lots of controversy, lots of argument, lots of discussion, lots of collaboration between the interventional community and also the thoracic surgery, the cardiovascular thoracic surgery who perform the coronary artery bypass surgery, and also the non-invasive cardiologists, because their input is very important, because usually in the eye of interventional cardiologists, always your belief is if I fix this lesion, patient will benefit, he'll be prevented from future MI, he'll be prevented from future days, he'll be prevented from any emergent procedure. So there is a thing called heart team approach. So eventually, after lots of going back and forth, the CT surgeon blaming the interventional, intervention blaming the surgeon, we came up with the heart team approach. Heart team approach is when there is really a complex cases, which could go either way, either PCI or CABG. Then the two discusses with the patient involvement and make a decision. Well, this patient will benefit from open heart surgery. This patient will benefit from a stent placement, or he has LAD disease and other lesion. Instead of cracking open the chest, probably let's go do a mini CABG to bypass the LAD, and just let's fix the other one with the PCI. because it's less, but they have their own really problem. With the clinical trial, the landmark clinical trial, which are really important for you really to focus on, was Courage. Courage is a big landmark, a big shakeup in the intervention community around, it's been going on for a long time, but it came out around 2010, 2011, 2012 area. And it just shook off the interventional community a lot in a good way, because what they were saying is whether it's one vessel, whether two vessel, whether it's three vessel disease, except proximal LAD and left main, some of them could be treated with medical therapy, and they do as good as you put a stent or you put a bypass. And the rationale was on those studies. In summary, what happened is those patients who are assigned to medical therapy, who are not very symptomatic, especially in stable ischemic heart disease, they cross over. There was a crossover of probably 30% or above eventually. How did that happen? They put them on medical therapy and they fail 2 or more optimal anti-anginal therapy after a certain time. Then they need PCI or open heart surgery. And that's really, it changed the landscape a lot. It shook off a lot. Lots of things come up, and it is in a good way. And then syntax was really for a complex cases with multivessel disease, left main, and calcification, complex anatomy. And they came up with the score, is PCI better, is bypass better, or either better. So with those options, they came up with the score up to 23, because you define the anatomy, the calcification, the bifurcation, a distal, proximal, all kinds of things. You can find, if you go to syntax score on the online, you'll find it in detail there. And it just come up with that. If it's below 23, PCI is good. If it's above 32 and 33 and above, open heart surgery is better. If it is in between 23 and 32, either are better. Barry is another study which focused on diabetes and other things. So in short, you can really go in detail about it. And then there is a recent Ischemia trial also, which suggested if patients have other than proximal LAD, left main, or major arteries, you can treat them medically unless they fail with the anti-angina. You shouldn't do it. With that comes, like, we have a tool for patients who don't have a stress test, who may have chest pain on and off. We can do a stress test during the Cath lab called FFR or IFR. FFR is fractional flow reserve. IFR is instantaneous fractional reserve flow, and you decide based on the gradient of the blood flow, which is measured equivalent by the blood pressure. Okay, so this is the guideline I was telling you about. And when you go to the top 10 take-home message, what are they? So treatment decision starting with the coronary vascularization patients with CAD are based on really clinical indication, not based on race or other things. And then what's the second take-off home? These are the most important things. So what I was telling you is a heart team approach. So we're not going into detail. That's very important these days. It's usually in the tertiary centers. And the third take-home message is when it is significant left main, surgical revascularization is indicated to improve survival. Relative to that, likely to be achieved with medical therapy. PCI is reasonable to improve survival compared to medical therapy in selected patients, low to medium anatomic risk, and left main is equivalent like proximal LAD and proximal circ. The fourth takeoff is especially with patients with normal heart function and triple vessel disease, surgical may be reasonable to improve survival. It's, again, maybe a survival benefit for PCI disease complexity, which I was talking about earlier, the syntax trial. Use of radial artery in STEMI and mostly is beneficial and improves survival because it reduces risk of bleeding. Unfortunately, when you do radial artery, there is a slight chance in stroke, but the recent studies didn't show that significant, but there is a tendency to increase risk of stroke. What are the 6 important things? Radial artery is recommended. especially in SCS and or stable ischemic heart disease. Especially, it has shown benefit in women as well as men. The early study was in women. So the seventh take-off message was the dual antiplatelet therapy. We have been really preaching, oh, everybody has to be on 12 menses, or everybody should get more than 12 menses if they can tolerate it. But now multiple studies came up in the last 5 years, which has shown we have to risk stratify patients, whether they are at risk of bleeding. Let me know when I have 5 minutes. When they are at risk of bleeding, or when they are really have AFib and they are on anticoagulation. So these are really very important. But usually, the best therapy is you put them on dual antiplatelet therapy for 3 to 6 months, and you can really put them only on monotherapy of P2Y12. But in other cases, in patients with ACS or STEMI, it is indicated they should be on 12 months unless they are at increased risk of bleeding, because blood transfusion increases mortality and future outcomes. And stage percutaneous intervention while in hospital, significant restoration of non-culprit artery is beneficial if it is not a complicated anatomy, and if you are not going to use more dye than expected, more than 3 times of the dye. That's another important thing. The other thing is percutaneous intervention of the non-culprit artery in shock, in cardiovascular shock, is not recommended it used to be indicated not long ago. And patients, don't forget, if there are interventional cardiologists in the room, if there are patients with cardiogenic shock, treating the non-culprit artery is harmful, which is contrary to the culprit trial, which was done in Europe. The number 9 recommendation is revascularization decision in patients with diabetes, multiple coronary artery disease are optimized by the use of a heart approach, which I was telling you earlier. Patients with diabetes have triple disease. Undergoing surgical revascularization is recommended. Percutaneous intervention may be considered if they are poor candidates. So the number 10 is treatment decision for patients undergoing surgical revascularization of coronary arteries include the calculation of patient surgical risk, which we talked about. So let me just show you some, just outline quickly. Relax, guys. Decision sharing with the patient is very important, and procedural assessment for the patient, whether they are stable to go or not, is very important. This is patient physics, patient-centered care in the treatment of coronary artery disease, shared decision making, defining the anatomy, which was about the syntax trial. I think I mentioned most of them. Revascularization in STEMI, especially the timing. You guys should read about it. Nothing much changed on that area. STEMI patient, they come clearly. Symptom onset is less than 12 hours. Is PCI feasible? Go ahead. If PCI is not feasible, large area of myocardium is affected, cabbage. Symptoms onset greater than 12 hours, cardiogenic shock, PCI is feasible, go for it. Otherwise, I think it's very self-descriptive. This one is a non-infarct related artery, which I just mentioned. In cardiogenic shock, it is harmful. But if the anatomy is okay and you are not going to give a lot of dye, more than 3 times the clearance, the GFR, you should go ahead with that. Hi, Dr. Singh. And this is the other one, non-STEMI. What's really the difference with a non-STEMI is there is 2 types. We used to profess if a patient has a non-STEMI, we can say we have time. We can wait. We can do it after 24 hours. But the difference is it's no more non-STEMI if the patient is hemodynamically unstable, electrically unstable. That means they are malignant. They have malignant arrhythmia, or patient is continue to have symptoms. They should be treated like a STEMI patients. And the timing of this is it's very clear. Cardiogenic shock, refractory angina, you should take them immediately to the cath lab. And at high risk non-STEMI, you should take them immediately. And this is the one which I told you about, the COURAGE trial and using of the FFR and other things. And so I think at the end of the day, I just wanted to show you one thing. When is it really indicated for PCI? PCI is indicated when the anatomy is favorable. If it is unstable angina, if it is ACS, unstable angina, ACS includes unstable angina, non-stimulation MI, STEMI, those are indicated in anatomy which is not complex. In the case of the left main disease, usually mortality benefit goes with the open heart surgery. Now, when the lesions are really like distal and not good for the either of revascularization, medical therapy is appropriate. Guideline mandated therapy with or without PCI are really appropriate. Do I have more time? There's one more slide. And especially this is, I think, it's an additional information for you guys if you want to really go into. Now, one very important thing which I really want to focus really in PCI is with CABG, there is an increase in stroke, especially on syntax trial, that's what they showed. With PCI, there is an increase with risk of kidney failure, contrast-induced nephropathy. And that has to be always emphasized. Whenever we decide to do any intervention, we have to make sure we optimize them. And this is very clear. One of the things which is really important is don't administer N-acetylcysteine to prevent contrast-induced acute kidney injury. And we have to make sure we give as little dye as possible. We have to make sure that we have to really prepare them with IV fluid. All the time, IV fluid, IV fluid, IV fluid. And that's very important. You have to really make sure that we are not going to destroy their kidney unless they really need it. Sometimes general procedural issues, radial femoral approach. There is a radialist, there is a femoralist. I think that's further detail for another time. But any question, I think we can address the rest of the things on a question. Any question from audience? Change it to back to the audience so we can see them.
Definitely.
You're welcome.
Dr. Demede, thank you for your talk. I think any questions from this here? No questions here. The biggest concern we have in the continent is the unavailability of early treatment for person having cardiac events. So I think that's a thing that we have to work on as a service deal in the U.S. If you have a heart attack, and really get it treated quickly. The time to door to treatment time is pretty quick. So I think getting a real nice scheme here in a country say for Nigeria, which is about 200 million, and making sure that one system works where people can reach that access point quickly would be helpful. So thank you very much, Dr. Demede.
I agree with you, especially this, I'm originally from Ethiopia. The same problem, probably Nigeria is better than Ethiopia with giving the primary PCI. There is a movement in Africa on those areas and really getting those, finding opportunity for patients. If not, they don't get it on the same day, if they can get it the next day. But the other issue is the supply issue. Like they don't get their material, like cath lab supplies, stent, even simple catheters. I don't know how that could be solved. That's a big discussion for us.
Yeah, it's a big discussion. That's the reason why we have this conference, is so we'll come up with creative ideas how to make those items more manageable and feasible here in the continent. Thank you, Dr. Demede. We have Dr. Shadi because he has to run to surgery very quickly. So we'll bring him up quickly, and thereafter we'll go to Dr. Shaw. Dr. Shadi is an associate professor of surgery. He comes to us from West Virginia University. He does endovascular vascular work, and he's quite good at it. And I would like to hear him talk on the topic acute mesenteric ischemia and the vascular options. Dr. Shadi.
Thank you, Dr. Can you hear me guys well? Or?
Yes, thank you.
Yes, we can.
And you can see it, huh?
Yes.
So we'll talk about acute mesenteric ischemia, the endovascular options. So acute mesenteric ischemia can be divided depending on anatomy, pathophysiology. For the sake of this presentation, talk about occlusive disease, typically embolic, thrombotic disease, which accounts for more than probably the majority, 70% of the cases of acute mesenteric ischemia that as vascular surgeon we deal with all the time. There's mesenteric vein thrombosis, which there's some endovascular, some open options. There's non-occlusive or NOMI that happens in sick patients in the ICU, and there's colonic ischemia that happens typically in sick patients also in the ICU. They have a small vessel ischemia, vasospasms. Sometimes you don't have to be sick. It happens with patients with steroids and other medication. There's other causes of acute mesenteric ischemia other than occlusive, like embolic or thrombotic, including vasculitis, FMD, and dissection, but that's a different topic. For today, we're going to talk about embolic and thrombotic. In general, acute mesenteric ischemia present with sudden onset severe diffuse abdominal pain. That's what you just have to hear the patient says: diffuse, severe pain, sudden onset. Typically, they have a normal exam. That's what we tell our students. They have pain out of proportion physical exam or physical findings. So they have soft abdomen, but they have severe pain. Peritoneal sign and acidosis are usually late. Patient could have atrial fibrillation, could have a history of some valvular disease, some maybe, unfortunately here in West Virginia and some other states, we have a lot of endocarditis that can be a cause of that embolic disease. Half of the patient with thrombosis, they have actually prior symptoms of chronic mesenteric ischemia. So they have weight loss. They're small, typically small ladies that are really heavy smoker. So the management in general will go quickly through it. If you really suspect them, scan these patients quickly. Start the patient a lot of fluids. Start the patient heparin, and get a CT angiogram. Get an EKG, get an X-ray, make sure there's no free air, free perforation, CBC, BMP, lactic acid, all that helps. But at the end of the day, you need to have a CAT scan. That actually helps a lot to diagnose and plan the procedure. Atrial fibrillation and abdominal pain. If patient comes in with new onset atrial fibrillation, abdominal pain, just please start the patient heparin, then we can just go and find something else. If you end up with a perforated bowel, you can just turn it off. It's very unusual to come with abdominal pain and they have a GI bleed, like from an ulcer or a bleeding ulcer. So typically, most of the usual thing that would happen to these patients, if they come in, they diagnosed with mesenteric ischemia, they end up going to the OR for expiration. You typically remove the frank perforation, the frank gangrene, and you leave as much as possible. Anything questionable, leave it there. Don't take it out because they can be viable. This patient can survive in a small amount of bowel without short gut syndrome. And then you revascularize. So to revascularize these patients, we try to do embolectomy in these patients. You try to do thrombectomy, retrograde stenting. So for the embolectomy, the just usual teaching is you expose the inframesenteric portion of the SMA below the takeoff of the middle colic artery. You reflect the middle, the transverse column mesentery up, and you expose through the root of the mesentery, the SMA. And we tell our residents, if the SMA is soft, you do a transverse cut, and you do a passive forward catheter proximal and distally, you get the clots out. And you can actually infuse some TPA, some nitroglycerin, some papaverine, helps with the spasm. But if the artery is heavily calcified, if there's a lot of calcification in the artery, you plan to do a longitudinal cut in these arteries and plan to patch, typically with the vein patch. But if there is a patient that has, again, you're trying to do thrombectomy, is not going through it, you have to try something else. So we had to do a bypass surgery. This is the picture I just put in because it's not a good way to do a bypass, which is taking a vein from the infrarenal segment. You take a piece of vein, you suture it to the artery, and the moment you let down the artery, the duodenum, it will kink the vein. So using a straight bypass coming from the infrarenal is probably the easy way, but it will kink the vein and doesn't help the patient. So a typical way, you can go from the iliac artery on the right side or far away below even the takeoff the IMA, or we can go from the superior mesenteric, from the supraciliac aorta. It's very soft artery, especially if you did not get a CAT scan and before the surgery. You just go supraciliac. Most of the patients that have soft artery there, you can side clamp that and bring a bypass. The celiac artery is going to hard usually go to the hepatic artery, or the SMA. You can bypass to the SMA. This is typically done in a retropancreatic fashion, tunneling. Another option is to go from the iliac artery again. This is a piece of vein, probably a femoral vein or even cadaver vein, that go from the left iliac artery to right iliac artery. Typically, my preference is to go from the right iliac artery, bring call a lazy C-shaped bypass. This is again using PTFE in these patients, mostly with chronic. There's a debate about what bypass we'll talk about. So is there any endo option? That's what we're talking about. If everything is advancing, we hear the talk about PCI and cardiac intervention. The world is changing. Can we just keep doing open for each patient? Probably these patients need open at one point, but the least we do open, probably less invasive, they can survive more. So we do have endo options now. It's not like 20 years ago when we have only balloons or just wires and balloons. We do have a suction thrombectomy, mechanical thrombectomy catheters. We have lysis. We have angioplasty balloons with different balloons. We'll talk about stenting, bare metal stent graft, which shows a better outcome. There is an atherectomy device that can be used in cases of thrombosis or disease. TPA infusion at the table, vasodilators, as I said, nitroglycerin or papaverin. Retrograde stenting, if you're in the hybrid room, you stick the SMA and you try to angioplasty the SMA or put a stent. So for angioplasty, the plain balloon angioplasty, there's a plain balloon angioplasty, works really well. There's drug-coated balloon. I never heard any studies about it now. Personally, I start using intravascular lithotripsy or shockwave balloon angioplasty for these patients in acute setting. Really, it does help a lot. These patients that have severe thrombosis of the SMA and celiac artery. The only problem with these balloons, they're longer balloons. There's coming out more shorter balloons for the tibials. We can use these balloons, but again, they're still long. But again, they will help a lot to end up with the cracking that plaque that is very hard to plaque. And we know that you put a bare metal stent, it barely opens up. So I start using it more aggressively in patients with heavy calcification. It really works like a magic in that location. Stenting, we talk about bare metal stent. It works really well, but we know the patency is over like 5 years, less than 50%. I personally, at the origin of the disease, I try to use stent graft like Viban VBX or ICAS or the V12 stents. I think they have better patency long term for sure, but you can definitely lose some branches. So try to use the shortest stent as possible. If you have to extend, you can use a bare metal stent that's self-expanding distal to the origin. I think that will be taken easier. There's a drug-eluting stent you can use, like Cook PTX stents that can be used. You can use drug-eluting stents, the coronary stents, but the biggest usually is around 4, which is we cannot expand more than 5. So it's not going to be very useful in a lot of patients. So how about mechanical thrombectomy? The old-fashioned I love this catheter. It's called Pronto catheter. They go from 5 French. There's a Pronto LP, and if you can see, there's a side port. What I liked about this is, and there's another device called Cath, and there's trauma catheters. But this one, I usually, when I cross the lesion, I put OM4 wire, and I can just suction the clot quickly to get some blood flow. It's like doing with coronary, just exactly acute MI. You suction the clot out, and I tend to inject TPA, around 10 milligram TPA, into the clot itself. That will help dissolve the clot and smash it when we try to suction it out. This is very helpful catheter. So 5 French, there's a 6 French. They both can go easy and they track very easy in the wire. There's a Cath 6 or a limited catheter also from different companies that also works really well. Again, they're over the wire. There's a side port in the side. When you go through the lesion, you can suction the clot out. More advanced mechanical thrombectomy catheter, like what I have here, the mechanical the Angiojet has been used for years for just declotting graft, for thrombectomy catheters, the IVC and in the DVT patients and some acute limb ischemias. I did use it in some patients. They go up to 8 French. It's pretty strong, actually, the 8 French catheter. My use of it is very less and less. There's some evidence of trashing and embolization. But again, I use TPA with these patients. So if I have no choice, I use it. But a lot of time I try to use something else. But it's very useful in these patients. This is what I like to use in these patients to suction the clots out, especially if there's an embolus. Now I'm talking about thrombus and talking about embolus. So there's embolus. I try to use the Penumbra catheter. There's a 6 French. There's 8 French. There's a 4 French coronary, but we have to use the bigger ones, like 6 French. There's a 7 French. Lighting is very good because it preserves a lot of blood. And it go up to 12, which I never had to use. I use the biggest one, 8 millimeter. I'll show you a case in a second. This is called mechanical thrombectomy Jedi. The good thing, it almost acts like a Penumbra, but has a jet at the end of it. And I'm going to show you just a picture here. It goes at the end of the catheter, and it can actually suction the clot out. How about mechanical thrombectomy? You can use laser. It has a suction catheter. You can use actually Phoenix catheter. I prefer this catheter for some of these patients. I'm just be careful when I say some of these cases, because this catheter is very stiff. The tip of it is between I draw these pictures A, B, and C. Between the C and the B portion is very stiff. So if you're coming from the leg, it can crack. I actually have one patient with a catheter got dislodged in the SMA and I have to go and snare it out. It was a little bit scary, but if you're coming from the arm with a heavy angle SMA, I think it would be useful. If you're coming from the leg, you have to be careful with the bigger catheter and sheath. But what's good about it, it can actually work as a thrombectomy, and if there's atheroma, we'll suction it out too. It works really well. This, again, we call the Rotarex catheter from Borg. So the first case I'm just presenting is 82-year-old male patient. He has history of open AAA 20 years ago with a tube graft. He just fixed a AAA. He had 1 day history of severe epigastric pain. He presented to the ER with gastritis. That's what they suspect. They call us because they found 4-centimeter iliac aneurysm. And I'm not sure why they consult us, but we end up going to the ER, see the patient. He was rolling in a lot of pain. His abdomen was soft. I didn't suspect, to be honest with you, acute mesenteric ischemia, but it's like there's something wrong. His white count was not elevated much. It's just 10,000. Lactate was 2.3. Exam was just a little bit tender, epigastric, no peritonitis. And I decided to relook at the scan to look at this iliac aneurysm and I found a big clot sitting in the SMA. So we discussed with him. He's 82-year-old. He's a new onset AFib, and he had actually hernia repair from with a mesh from the previous surgery that he has an open AAA. So with his age and multiple surgeries before, I decided to go with endo. So we started patient heparin, gave him some IV antibiotics, took him to the Cath lab, put a 6-French sheet femoral axis, did an angiogram of the SMA, and you can see the clot sitting in the middle of the SMA beyond the takeoff of the middle colic artery. He's lucky because there was some flow going around the clot at that time, although he was not anticoagulated. We end up upgrading to 8-French sheet, 45 centimeters. I inject actually 10 milligram TPA through the clot. I use a Penumbra 8-French thrombectomy, and I infuse some 60 milligram papaverine just slowly over like 5 minutes to break any spasm in the distal branch, and you can see the outcome great. We give them a lot of fluid boluses, and that's very important key for these patients. You have to give them, you have to flood them with a lot of fluids if you decide to do this, because they will end up with some ischemia and vasospasm after you open the blood flow, and you have to break it with some fluids, a lot of fluids, which can lead to compartment syndrome sometimes. This patient was made to the ICU. We had serial abdominal exam. He never had peritonitis. We did the serial labs. All his white count was normal. Lactate was normal. Next day, he was giving Xarelto, which is a newer anticoagulant, and he went home. And I saw him 6 months out. He was completely fine. The case 2 was a bit different. His 60-year-old male patient, heavy smoker, sudden history of onset abdominal pain, severe. He had mild diffuse tenderness, but no peritonitis. White count was 14,000. Lactate was 3. CTA shows occluded SMA, and we started with some fluids and heparin. He does have history of pancreatitis in the past and pseudocyst formation. I'll go through this image here slowly, and I hope you can see this CAT scan. And people say, well, you just take him to the OR and just do a bypass. And this is very typical why CAT scan will help a lot. You can see the heavy calcification, the celiac artery now, and the SMA, and the infrarenal segment of the aorta is just heavily calcified. It looks like it had a whole shell. There's no place to clamp. And he has also kissing stents that we did not know. It was done outside hospital. So there's no place to come except maybe from the external, which I don't prefer that as a bypass target or origin. So in this patient, we took him to the angio suite. This is the angiogram through the SMA. You can see it's completely totally occluded. I end up putting a steerable catheter or sheet, and my preference later on was use more as a stiff catheter and stiff wire, and I was able to cross the lesion. And this is the angiogram after we did the lesion. I did TPA in the lesion. I've exchanged to 014 wire. And this is just after a TPA and the Pronto catheter suction thrombectomy. We angioplasty with this patient with a regular balloon, and then we exchange to a shockwave balloon. Was just we use like a 5 balloon. And this is just after angiogram with a shockwave. But because we know the heavy calcification and the disease is going to come back, we end up actually putting a stent in this guy. And this is just a final result. You can see the SMA is wide open. So he did actually have an X-lab because his abdomen pain was starting to increase, which probably he has to suspect also some ischemia. He had a bowel resection for a short segment, probably like 10, 20 centimeters with a primary anastomosis. So we didn't have to actually do another second look. He has a prolonged hospital stay for probably 2 weeks because of his lungs. His lungs are horrible from smoking. Later on, he was discharged home on aspirin and Plavix. So why we just do endovascular? If people ask, why we just do open? Everybody get open. The answer is not everybody needs abdominal exploration. Some patients, if you can avoid this invasive surgery, if they have no peritonitis, they don't have any severe elevation, why can't severe lactic acidosis, why just not do open endovascular and just watch them and examine them? And if they end up with even laparoscopic exploration and just we can take the bowel. The endovascular reality is depends on the hospital you work at. If you can assemble the team, you don't have to call anesthesia, put him asleep, you can just do it under local. So you can, especially in the patient that has a redo abdomen. Redo abdomen is disaster just to get into the abdomen with all the scar tissue. And there are different low risk of infection with, of course, the question is, we can argue about what conduit to use for bypass. If you have a PTFE, I personally use PTFE even in acute abdomen because I just want to get the patient some blood flow to harvest the vein, and try to put it there and make kink and not kink, and it just may end up with actually more prolonged procedure, more ischemia to the bowel, and possibly less bleeding. Although if you're using TPA in these patients, there will be some more risk of reperfusion. And again, let's just face reality. We have younger generation that are really more comfortable with endovascular procedure. They really don't have to review YouTube videos just looking at how to explore the SMA, which unfortunately doesn't happen a lot. I want to do these procedures, but not in a patient that's acutely sick. And how to do retropancreatic tunneling. Every time I do retropancreatic tunnel, which happens probably once a year, I'll be really concerned about the pancreatic vein and just torturing the pancreatic vein. It just, so why not do endovascular? Patient with severe sepsis, they're in shock, there's no doubt. Just take them to the OR, explore them, and fix them. If they have peritonitis, especially generalized peritonitis, don't waste your time in the CDL. You can go to hybridome if you have and try to retrograde stenting, but if they have peritonitis, don't waste your time, go to the OR, do an open procedure. Extreme elevation of white count. There's more studies shows even 15,000, it probably had to be taken to the OR, and there's a risk, more evidence that they will end up with some dead bowel. But I would just say if 20,000 or more, if severe lactic acidosis more than 3, 4, I would just probably take them out. If they have pneumatosis or free air in the X-ray, probably take them out. Don't do endo in these patients. And just tips and tricks for this endovascular management. You start the patient heparin immediately. You get a femoral axis or brachial axis. Although there's more devices coming out from radial axis, and I have been started using more radial axis for some of these patients. It works like a magic, but again, we don't have all these toys and catheters and stents that can probably reach, especially if the patient's tall. Get adequate support from the beginning. Be careful. If you have these steerable sheets, people call them MOF, Destino, Torque Guide, all these devices will help you a lot to cross the lesion. So be aggressive using steerable sheets from the beginning because it will help you to cross lesions. And use stiff catheters as Navicross or Quick Cross, or you have a patient that has glide wire and all that, glide cath, it's probably not going to be enough to have support to cross a lesion that is heavily calcified. Again, use a stiff wire. When you cross the lesion, it just exchange to over 4 wire with a good support. Like I use the Sparkle wire from Abbott. I infuse TPA in the proximal segment or inside the clot, and this will help also in the branches later on. I typically use around 10 to 20 milligram TPA. Suction thrombectomy, the proximal clot, I use Pronumbra. I use Pronto catheters. Sometimes I Uterex, but again, be careful if there's a lot of calcium because they will get stuck on that calcium if you're using Rotarex. PTA and stenting, I prefer at the origin disease of a covered stent, and if you have liberally extend distally, if you're doing this just to get the mud flow as possible. Shockwave balloon and other atherectomy devices in heavy calcified lesion will be very helpful. Be liberal in using vasodilators as long as the blood pressure of the patient weight. Use a lot of fluids if you have a lot of fluids. And if you do lysis for these patients, do not wait more than 4 hours, please. Don't just put a lysis cath and come back next day. You have to take them within 4 hours because this patient is not going to tolerate ischemia. If this catheter is not going to work, just take them and do a bypass or do a thrombectomy. Again, you can just do Plavix after them. Now, if it's taking too long, you got to go to the hybrid room or go to the OR. Give them a lot of fluid bolus at the beginning and give them a lot of fluids after to break the spasms, and watch for abdominal compartment syndrome because these patients sometimes will have developed that. The final thing is who's right and who's wrong. Should we do open or not? Vaccine, not vaccine? There's no good answer now, but I think we're heading more and more toward endovascular, which will help a lot of patients. Thank you so much.
Thank you, Dr. Shadi. Thank you very much. Any questions before he leaves? He has to go to work.
I just want to ask, thank you for the presentation. I want to ask if low molecular weight heparin might suffice as an alternative for heparin.
What's the role of low molecular weight heparin? Is a question.
I mean, to start with, we always give these patients full dose, like a heparin drip. We don't use just like Lovenox or Fragment or all that. I think it's just better just to keep them in heparin, just in case of any signs of bleeding, which can happen. Some of these patients will end up with bleeding. The reported case is more than 20%. They will have some bleeding complication. So you don't want to just give them Lovenox and they will bleed and you cannot reverse it. But after the procedure, you can just, typically these patients, if they're in continuity, you can just give them aspirin Plavix. Unless they are on, they have AFib, you have to put them on like anticoagulation, like warfarin or Coumadin or Eliquis. But I typically don't use Lovenox unless they just after the procedure.
Any further questions? Any questions? Shadi, any experience with endarterectomy at the origin of the SMA or the celiac?
Yeah, that's a fun operation, Dr. I mean, to do the trapdoor and do endarterectomy, I think it works beautiful, but it's pretty morbid. This is basically reality. You have to cut the diaphragm and you have to clamp. I tried to I did it probably 3-4 times in my life, and to do just a side clamp, as the book say, it's really hard. These patients had a small aortas, and typically you end up clamping the aorta for probably 30 minutes with the ischemia to the legs, and it does work, but you have to be careful, and it will work. But if you have this we call coral reef lesions, that's probably difficult. I think bypassing these patients will be easier and faster, unless both the SMA and origin just exactly at the origin, not like more than a centimeter or two into the SMA and the celiac artery.
Very well. Thank you, Dr. Shadi. Appreciate it. Thank you. Good luck with your case right now. Thank you later.
Thanks for that.
Okay, thanks. Bye-bye. Okay, our next speaker is Dr. Palma Shaw. She's coming to us from Syracuse, New York. She is endovascular vascular surgeon and also the program director for the vascular surgery program at City Upstate. She'll be talking to us today on the management of pulmonary embolism as one talk, and the second talk will be management of complex aortoiliac occlusion. So, Dr. Shaw, and also she is the incoming president of the ISEVS. She'll be succeeding Dr.Ourania Preventza that you all seen earlier. Dr. Shaw, thank you.
Hi, Dr. I'm having trouble sharing screen. I don't see where I can share screen on this. They have my videos as well. I just don't know how to share.
Is the box beside the mic icon there for you?
I clicked on it, but it doesn't allow me to see anything else to do.
No, something underneath titled desktop/window did not pop up.
It just says open share tray.
Yep, do that. Open share tray, and then
Okay.
underneath it would say desktop/window.
No, it doesn't.
Oh.
Okay, we could play the video and you come back.
Play the video and I'll just be on for questions.
Yeah, we'll play the video and we'll come back to you and you can give us the questions. Yeah. Okay. Let's play the video. Okay.
Thank you, Dr. Shaw.
Sure.
Thank you.
Good afternoon, I'm Dr. Palma Shaw from the State University of New York, Upstate Medical Center. It's my pleasure to be here today to discuss the management of pulmonary emboli and update. I'd like to thank Professor Oye and the organizing committee for this kind invitation. I have no important disclosures related to this discussion. Pulmonary embolism is a major cause of morbidity and mortality in the United States. It is the third leading cause of cardiovascular mortality. Even after treatment, 3-month mortality is about 15%. Management of acute PE remains poorly standardized, and PERT teams, or pulmonary embolism response teams, are being established around the world to provide rapid, individualized, and expert-based care for patients with acute PE. Pre-procedural planning is important. Patients are assessed by the PERT team. They take into consideration the hemodynamic stability, respiratory status, such as O2 requirement, bleeding risk, coagulopathy, presence of prior chest radiation. Pre-procedural imaging includes CT pulmonary angiogram, echocardiography, and lower extremity Doppler ultrasound. CTA can demonstrate the location and clot burden in the lung, and the chronicity of the clot can also be assessed. The size of the right heart, be it the right ventricular to left ventricular ratio, can then be measured. In consideration of their bleeding risk helps determine the tolerance for pre-procedural anticoagulation. One should note that clot may shift location between the initial CAT scan and the time of intervention. The treatment for acute pulmonary embolism includes systemic anticoagulation, which is a standard of care. More aggressive treatment can be considered in the setting of massive or submassive PE, given the high mortality risk. This is clearly an immediate concern. Additionally, a secondary consideration is the prevention of the late onset chronic thromboembolic pulmonary hypertension condition. Treatment options include systemic thrombolysis, catheter-directed interventions, and surgical thromboembolectomy, and more recently, endovascular mechanical thrombectomy. Considerations for intervention include a reduction of acute mortality, which is 25 to 50% in massive PE, and 12 to 15% for submassive PE. Downstream problems include residual pulmonary vascular obstruction in 30 to 50% of patients. Clinically significant predictive factors include heart failure, pulmonary hypertension, and decreased quality of life and death. Removing the large clot burden quickly improves acute right heart strain, while reducing residual clot predicts improved long-term outcomes. The PERT team is activated in the presence of moderate to severe dyspnea, hemoptysis, moderate to severe chest pain, tachycardia, elevated troponin, or right heart strain. Systemic thrombolysis can be beneficial in the setting of massive PE. However, it appears to be associated with a higher rate of major complications compared with catheter-directed thrombolysis, as shown in recent randomized trials for submassive PE looking at use of catheter-directed therapy. This group from Pittsburgh suggested an algorithm for management of the acute pulmonary embolism using catheter-directed therapy, stratifying this between low-risk, submassive, and massive PE. I would suggest that you can introduce the consideration of mechanical thrombectomy here to treat submassive and massive PE. There are patients in whom thrombolytics would be a contraindication, and this needs to be considered, particularly any prior intracranial hemorrhage, structural intracranial cerebrovascular disease or neoplasm, ischemic stroke within 3 months, or suspected aortic dissection, or other active bleeds need to be considered. A retrospective review was conducted of all patients treated for submassive PE. There were 2 groups, anticoagulation versus catheter-directed intervention. There were 64 patients in each group, and at 90 days, there was no difference in PE-related death or major bleeding events. Catheter-directed interventions demonstrated more minor bleeding events, but a significantly shorter intensive care unit stay and a non-significant lower overall 90-day mortality when compared with anticoagulation alone. At 1 year, echocardiographic parameters, the presence of pulmonary hypertension greater than 40 millimeters of mercury, dyspnea, and oxygen dependence were not significantly different between the groups. Surgical pulmonary embolectomy is an option for patients with severe PE and contraindications to thrombolysis or who have persistent hypotension after initial therapy. Previous outcomes reported for surgical pulmonary embolectomy have generally been limited to small cohorts. And in this present study listed here, the authors evaluated nationwide outcomes for surgical embolectomy for acute PE. And in that study period, 2,709 eligible patients were identified as undergoing surgical embolectomy for acute PE. The overall inpatient mortality rate was 27%, and they did find that Black patients were more than 2-fold likely to die during that hospitalization than white patients. This is another modality, which is the ECOS ultrasound-assisted chemical thrombolysis device. This uses ultrasound to augment catheter-directed therapy. Investigators have looked at this, its safety and efficacy. The assigned catheters are placed into the affected pulmonary arteries in the study for 45 patients. 13 of the patients received an average bolus of 30 milligrams of tissue plus an activator. with an average infusion dose of 21 milligrams. There was an improvement of hypotension and tachycardia. Direct pulmonary artery pressure measurements showed an average decrease of 21 millimeters of mercury. Post-procedure echocardiography demonstrated complete resolution of cardiac dysfunction in 64%. There were no deaths through 90 days of follow-up with no major procedural bleeding events. This study looked at 25 patients who underwent 33 catheter-directed interventions for massive PE. ECOS performed in 45%, catheter-directed therapy in 55%. Comparing treatment success based on thrombus removal, the ECOS treatment resulted in improved treatment outcome compared to catheter-directed group, although the numbers are small. The mean time of thrombolysis in the ECOS and CVT group was significantly less, and the mortality rates were not significantly different. So they concluded that when comparing ECOS to catheter-directed therapy, ECOS provides similar treatment efficacy with reduced thrombolytic infusion time and treatment-related complications. Another device that was recently released is the Bashir Plus endovascular catheter by Thrombolyze. This is introduced through a 7-threaded sheath in the femoral vein. It's intended for controlled and selective infusion of thrombolytics into the peripheral vasculature, enabling restoration of blood flow in patients with venous thrombus. It's approved for deep vein thrombosis, but is also now being utilized in pulmonary embolism management. The distal fusion segment of the device is 12 centimeters long and consists of an expandable basket with multiple mini infusion catheters, each with multiple infusion holes. This may reduce treatment time and permit a single session of catheter-directed therapy in acute PE. Here you see the infusion basket can be expanded in the lower picture using the red actuator located on the handle at the proximal end of the device. Then after you expand it, you can infuse the lytic, and then you can deflate it, reconstrain that and remove it. And this just shows you that this basket, when closed, is a 7-French catheter. It's very atraumatic to the vessels and easy to use. And then when it's open, it's expandable with a nitinol basket that will then go through the acute thrombus, and then you can infuse the lytic right into the clot. There's 6 different channels for uniform lytic delivery inside that clot. The rescue clinical trial is now underway to assess the use of the Bashir endovascular catheter for treating acute submassive PE. They intend to recruit 125 patients with endpoints of primary efficacy, a difference of RV-LV ratio of 48 hours after completion of the TP treatment, looking for major bleeding within 72 hours. And the secondary endpoints include evaluating refined modified Miller index, occurrence of recurrent PE through 30-day follow-up, clinically relevant non-major bleeding, systolic PE pressures, and cardiac output and cardiac index. Factors favoring mechanical thrombectomy include large clot burden and submassive or massive PE in patients with useful in patients with who have contraindications to lytic therapy and the need for more urgent expeditious relief. The Indica system, Lightning 12 mechanical thrombectomy device has a soft trackable atraumatic tip with pump-based aspiration that provides a full vacuum for the duration of the procedure. And you can see to the right that the catheters are angled. The Indica thrombectomy system permits a large removal of a large amount of clot retrieval with or without a lytic agent. The Inard flow treatment system has a sheath that's 20 French and one that's 24. This allows, because of the size of the sheath, this allows for rapid aspiration of clot using a 60 cc large bore syringe. And if clot gets trapped, or if you need to facilitate extraction of the clot, you can use these flow treatment discs. Tools that are needed to perform these procedures include a micropuncture kit, ultrasound guided access, 6 French sheath to start, and then a sondier or rolling catheter to cross into the pulmonary arteries, then a dilatation kit, a working sheath up to 20 if you're using the Inari, or 12 if it's the penumbra, a supercore wire or other stiff wire to help get that sheath across into the pulmonary artery safely through the heart. This is a case of a 53-year-old female who presented with dyspnea and fatigue in a recent syncopal episode in the fall. She was hemodynamically unstable initially, but responded to fluids. She was not tachycardic and maintained a mean arterial pressure of over 70 and O2 sat 91%. Because of the recent fall, it was felt that TPA was unsafe. And a CTA demonstrates a massive saddle embolus extending into both pulmonary arteries and right heart string. The Roman catheter was able helping advance the wire into the pulmonary artery. And here you can see the initial angiogram that I performed with the sheath in place. Then there's some improvement after I was able to aspirate the right side. And then this is, I was able to treat the left lower lobe and left upper lobe. And then there's a completion that shows good filling, and here's the clot that we removed. This case, a 39-year-old male with shortness of breath, presented following a syncopal episode. His history of chronic with PE 5 years previously, treated with a deregulation, but then stopped after 1 year. He is CT demonstrated acute pulmonary emboli with saddle embolus, prominent central emboli with severe clot burden, and findings of right ventricular heart strain. Here's the initial image. And treatment of the left and right pulmonary arteries. Here we were able to remove not only acute thrombus, but chronic thrombus as well. And here's the completion image. Symptomatically, he was much better. There are a variety of safety studies trying to compare these approaches to treating PE. Some of the flow treater, which is the NRI system, and the Python system uses TPA, Seattle-2, which uses the ECOS, and then Optilis P used the ultrasound catheter-directed therapy. You can see with the flow treater, the risk of intravenous hemorrhage is 0 and major bleeding is much less. And when you look at different clinical trials, and you also include the data from the Thrombolex trial, you can see that with respect to the acute relief and improvement of the RV-LV ratio, the Thrombolex device appeared to be superior compared to other devices. Additionally, it showed a higher clot burden reduction. Furthermore, when you look at the major adverse event rate, major bleed rate, and procedure time, this showed you some comparison of the different devices that were in this comparison study. The Thrombolex device showed improved outcomes compared to some of these other devices. At our institution, we looked at our patient data to see how our requirement to create a protein in the midst of the pandemic and increased rate of thromboembolism impacted our process of taking care of patients. Very abruptly, we had to all learn how to do pulmonary embolectomy mechanically, and we did. And in 2020, we did 29 patients that were treated for submassive PE, diagnosed by oxygen requirement, RV strain, right to left ventricular ratio by CT scan. 76% had improvement in respiratory function, 83% had improvement in pulmonary artery venous pressure. That we had no procedure-related deaths in those patients treated by our service. So I would say in conclusion, we need to consider the benefits of reduction of predictive adverse outcomes, such as the RV dilatation, large clot burden, and central clot location. Mechanical thrombectomy is the device, one of the devices. There's a number of options here. Will allow for large clot removal in both chronic and acute disease. But there are also newer lytic catheters on the market as well, when you can use lytic agents. These are great additions to the endovascular specialist toolbox. We need more data about long-term outcomes. But overall, our goals for pulmonary embolism intervention include reducing right ventricular strain, increasing pulmonary arterial flow, increasing lobar perfusion, removing clot, and then improving our clinical outcomes with reduction in mortality, improved quality of life, speedy recovery, and reduction of adverse outcomes, which includes mortality, pulmonary embolism recurrence, heart failure, and dyspnea. Thank you so much for your attention and the opportunity to participate in this outstanding forum.
Thank you, Dr. Shaw. Nice talk. Any questions from the audience? I have a question for you. I'm quite familiar with the ecosystem. It works quite well. I'm not too familiar with the, I haven't used the Thrombolex system. What's the cost implication for Thrombolex? Because it looks not as cumbersome as ECOS, just looking at it. looking at the African experience, how one can translate a system that's easy to use and hopefully not too expensive, so people here can benefit from technology.
So I don't know the cost off the top of my head, but the Thrombolex, the facility of that is it's a smaller sheath. It's just a 7 French sheath. And the nice thing about the Thrombolex system is that basket just acutely opens up these already blocked vessels, so they see a much quicker response. Having predominantly used Inari and the Penumbra devices, tracking those bulky sheaths through the heart can be a little bit concerning, even for a vascular surgeon. But I've done it without consequence. I can say I've had no complications doing that, but there are risks in putting a 24 French sheath literally through the heart and all the way across. So I think that probably the learning curve and the safety at the end of the day may be easier with the Thrombolex, but the patient has to be able to have lytic therapy. So the nice thing with Penumbra and Inari is that you can have a significant improvement in a patient that can't have anticoagulation. So that there's probably no one perfect device, right? There's several.
That's correct. Very well. Thank you. Interesting and nice talk. I do know of persons here in the sub-region that have died from PE. So I know it's a needed technology. They do have some thermolytic therapy, available, but not sure how well coordinated they are in terms of expense. So I'm thinking we should probably look at the possibility of doing like a PE type program. Select centers may be helpful for them, so that way select physicians here locally who can do the procedures can. We do have a good crop of cardiovascular surgeons here that do great work, so that would be the starting point. And we'll continue to have that discussion and go from there. Thank you very much. We'll have the second talk ready if you're ready for it. Yes? Oh, there's one more question for you, Doctor.
Sure.
Dr. Shelley is a cardiovascular surgeon, has a question. Dr. Shelley, go ahead.
Oh, thank you. Can you hear me?
Yes, we can.
Oh, thank you. Sure. I enjoyed your presentation because we are currently faced with one of our patients who has a DVT and at the same time has a pulmonary embolism. I just want to find out from what you said, mechanical thrombectomy may be indicated when you have submassive as well as massive. Between submassive and massive, when do you really determine you will now do mechanical thrombectomy? Sorry, I was a little bit late to the presentation because of the internet connectivity.
Sure.
But I would like to know at what point will you decide between submassive and massive? For us here, we're a little bit more conservative because we don't have the kind of technology you have. Even when they are submassive, we still go with anticoagulation, and we have to decide whether we need to do thrombolysis and things like that. So what will be your advice for us here on how to approach such cases?
Yeah, thank you so much for your question. I totally understand where you're coming from. I will admit that prior to the pandemic, I had never done a pulmonary mechanical thrombectomy. It was a totally new thing for our entire group. And now 4 out of the 5 vascular surgeons can do this procedure, and we have pretty good results. And it's been important for the hospital that we took this on because the interventional radiologists and cardiologists, they weren't getting our results, believe it or not. So we've had to continue doing that and become part of this organized PERT team. As far as the submassive and massive PE, we really end up doing the procedures, except when the patients are truly unstable. If they're really too unstable to leave the ICU and come into the lab, then there are a few that we've decided that we couldn't intervene upon. But I would say the large majority of patients have done pretty well. And once you've hydrated them, they do better. And I think when you're learning these techniques, I totally recognize that if you don't have support, we have representatives from the companies, they come to support the cases. they can help, when we started learning how to do this, that was very much helpful. So in your position, whether there's representatives from companies available or partner vascular surgeons who are already doing this could come and spend time and bring your group up to speed, that might be something that's helpful to launch that.
Thank you.
Yeah, along those lines, Dr. Shaw, one of the limitations in this climate is the fact that the technologies are not readily available. And if they were readily available, they'd be quite expensive. The per capita income is quite low. So what can the ISEVS do to mitigate that difficulties that physicians care face by engaging the industry of those companies to look at the continent more favorably in such a way that once their product is getting close to expiration, maybe 6 months, then give those products at markedly reduced rates to this third world countries so they can provide the care necessary when they encounter patients such as these.
Yeah, I see your point. I guess clearly it is challenging to engage in those conversations with different industries on a global scale. My experience managing fund recruitment or cost with on a global scale is a little bit more challenging than if you're just within the United States in the national, even raising funds for different international entities that I work for, such as the World Federation. We were unable to really raise money in a global way. And I hit barriers in doing that. So I think ISEVS can certainly start engaging in those conversations to raise awareness. But I think that different industries have to have different mechanisms to get some probably financial relief to do these type of voluntary or these efforts that are almost missionary in a sense, right? Providing a lesser cost to your groups that have less funds. We're not currently engaged in doing that, but I do feel that somebody should do that.
And what about ISEVS directed clinical research in some institutions here that are available, that may have the staffing to provide the care, but just don't have the means to provide the care? Would there be a possibility for clinical research that may force those companies to come in and provide care because they're doing the research here too?
So you're saying to have them do clinical research that is occurring in Nigeria, for example?
Right.
I think it's a need. I don't have experience discussing that with industry leaders, but we certainly can at the upcoming the VEITH meeting is coming up, and we will all be there speaking with industry at our board meeting during the session. So we can bring that point up and maybe get back to you regarding that. It's a great idea.
Thank you so much. We'll get on with your second talk.
Okay. Sure.
Second talk from Dr. Shaw again would be the management of complex aortoiliac occlusive disease. Thank you, Dr. Shaw.
Sure.
Good day. It's a pleasure to be here today. I'm Dr. Palma Shaw from City Upstate Medical University in Syracuse, New York, in the United States. It's an honor to be here as the International Society for Endovascular Specialists President-elect during this forum that's honoring Ted Dietrich, the founder of this society. I'd like to thank Dr. Herbert Oye and the meeting planners for the opportunity to participate in this outstanding forum. I'll be discussing the management of complex aortoiliac occlusions. These are my disclosures. The global vascular guidelines have laid out a management strategy for managing chronic life-threatening ischemia with comprehensive medical optimization and then other strategies to preserve lower extremity perfusion. We do know that the gold standard operation for managing aortoiliac occlusive disease is the aortic bifemoral bypass. This is a somewhat high-risk operation in this particular population with a number of potential complications, all listed to the right of the screen. However, there are good five-recurrent patency rates if the patients do okay, ranging between 85 to 90%, and a 10-year 75 to 85%. But the morbidity ranges from 4 to 8% and mortality from 2 to 4%. So we are looking for better ways to manage these patients with a lower morbidity and mortality. When we consider occlusive disease and stratify it based upon the task 2 classification from type A, B, C, and D to the right of the screen, we also have to recognize that the AIOD typically involves not only the aorta, but will extend into the iliacs, into the common femoral artery, superficial femoral and component femoral arteries in up to 40% of the cases. And the patient symptomatology may range from mild claudication to ischemic breast pain. More widely employed, endovascular treatment has been performed in type A and B task lesions with an excellent success. More and more often, we're trying to consider application of endovascular therapies in the task C and D lesions. As we push the envelope from direct stenting and selective stenting through self-expanding balloon expandable stenting of the iliac vessels, we consider the merit of covered stenting compared to uncovered stents in the Kissy technique to treat these lesions. Midterm primary patency rates have been shown to be 84 to 92% using covered stents. Other operators have used aortic construction with balloon expandable stent grafts. This group looked at 32 patients with asymptomatic task 2D aortic occlusive disease who underwent either surgical bypass or endovascular reconstruction. To the right, that listed all of the things that they took into consideration with respect to the aortic and iliac disease, stenosis and occlusion, the lesion length, the lesion location, bilaterality or unilaterality of the lesion, as well as the presence of an outflow obstruction. They found that 2.7 years, endovascular reconstruction surgical bypass showed equivalent rates of survival, limb salvage, and primary or primary cystic patency rates. Additionally, these groups showed similar clinical improvements in walking distance, breast pain, and tissue loss in 30 days, and even at long-term follow-up. Overall, they concluded that the outcomes of endovascular reconstruction versus a large open surgical bypass for these lesions may be equivalent at 2.5 years after the procedure. This group looked at a hyperrevascularization using an iliac femoral endarterectomy combined with iliac stent grafting to treat the class C and D lesions. They had 36 male patients, and the indications for surgery were either claudication or breast pain and tissue loss. Simultaneous adjunctive procedures were required in 22% of the patients, three of which also required stenting. This group demonstrated that at a mean follow-up of 23 months, ranging from 1 to 79 months, primary patency was approximately 85%. Cumulative primary assisted and secondary patency was as high as 92%. Their most frequent site of reintervention was femoral patch repair in 3 out of 3 range patients, and the 2.7% mortality in 3 days was quite acceptable, although in the long, durable duration of the study period, the mortality was 34%, and they felt that this was reflective of the high-risk nature of the patients that were treated. And they concluded that hybrid approach had a low morbidity and mortality at 30 days. The COVAS investigators looked at the use of covered and bare metal stents, and they showed that there were similar and acceptable results in task B lesions, but that covered stents fared better with the longer term patency and clinical outcomes for the task C and D lesions. This group looked at endovascular treatment of task D lesions using a unibody bifurcated endograft. In this small series of 10 patients who had respiratory tissue loss and were deemed high risk for aortobifemoral bypass, they performed endovascular reconstruction using the Endologix unibody aortic device with a 100% technical success rate, and all patients reporting clinical improvement resolution of ischemic symptoms with a mean echobrachial index improvement of 0.5 over a follow period of 40 months. Primary and secondary patency rates were 80 and 100%. When they did have to re-intervene, one was for an expanded hematoma at the axis site, one was an acute iliac artery thrombosis, and one patient required angioplastic stenting for threatened endograft limited 4 months. This group, which was a multi-center experience, looked at the unibody endograft for treatment of this problem. They had looked at 90 patients, 54 of which were male, in 10 different centers. In these cases, 41% were percutaneous, 60% required adjunctive procedures. There was a low 30-day mortality of 1% and a low complication rate with a good technical success rate of 98.7%. Overall, 80% of their patients experienced improvement of Rutherford stage of 3 or greater compared to baseline. So just to show you an illustration of the concept of recreating the aortic bifurcation, you may say that previously we were doing kissing stents that may ultimately be undersized to the left. If we use larger stents, we may take up more space, and if we can use larger night-mount stents, we may have a bifurcated situation, but it's taking up more of the volume of the aorta. And in the unibody device scenario, you have completely used the entire surface of the aorta. Guerrieri and his colleagues have published their technique on covered endovascular reconstruction of aortic bifurcation, also called the Serrat technique, which at that time was new, but now is widely employed by many operators. Just to review a little bit about the technique itself, they use a 12mm balloon expandable stent positioned and deployed 1 to 2 centimeters above the aortic bifurcation. Then the more proximal portion of that covered stent is overdilated to ensure that it opposes the aortic wall. And then the Serrat configuration is completed when they simultaneously inflate 2 iliac balloon expandable covered stents in the convex segment, molding the first one around the latter 2. They looked at the 3-year outcomes with 130 patients, 69 of which were male. 68% had intermittent claudication, and the remainder had critical ischemia. The majority of which were class 2D lesions, and the rest were B or C. Primary assisted and secondary PAC rates were 86%, 97% at 1 year. They were 84, 89, 97% in 2 years, and even in 3 years, they were still fairly good at 82, 87, 97%. Just a few tips and tricks for success. I think careful preoperative planning is very important in these cases, also to ensure that you have the correct device sizes in the lab. I always have bailout options if I can't cross. I prep the groins, the left brachial, the abdomen, and consider whether or not I may need to do an axillary femoral bypass in that particular case. Furthermore, you need to consider the presence of previously placed stents and what those sizes may be, as this may constrain how the stent that you may be able to use ultimately. You also need to be sure that you have adequate runoff and be prepared to do a patch angioplasty or bypass if necessary. I always try to preserve the internal iliac artery if feasible, although oftentimes it's quite diseased and may already be included. I often use balloon expandable stent grafts because they have better rate of force and better location of deployment accuracy. But more distally, I'll use self-expanding coverage stents, particularly if I'm extending down towards the joint. At our institutional experience, we evaluated this in our population. We did, again, pre-op planning based off the CTA to get target vessel diameter and length. We tried to anticipate in advance whether or not we need to do a common femoral endarterectomy patch angioplasty based upon whether or not there was more than 50% reduction in the arterial diameter. You have to consider the fact that you still need to recanalize, and how you're going to recanalize is included iliac or aortic vessels, whether you can come from below, across, over the top, or from above. And now with the directional sheets, you may not have to go from the arm as we did previously. Pre-dilatation may be necessary to allow for delivery of the stent grafts. And then I would deploy a 1mm VPX and then balloon that out further based upon the size of the aorta, over dilating approximately, and then completing this with the iliac stent grafts. This is a list of all of the comorbid factors in our patients. You can see that ASA class 3 or 4 was fairly significant, 86-14%, and CAS deletions were 79% of the cases. Complications we encountered included a distal dissection flap, including the left internal iliac, which was treated by a covered stent graft. Presence of aortic thrombus with the proximal end of kissing iliac stent grafts treated with a parallel stent graft. A perforation of the left lateral circumflex artery side range, which required opening the incision and ligation of that small branch. Treatment of residual distal left common artery stenoses, 1 axis hematoma, 1 inability to cross the lesion, so I converted to an AUI and bypass graft, and 1 inadvertent occlusion of the internal external iliac bifurcation. But overall, we had improved perfusion with the improved pre-op ABI to 0.62 and 12 sorry, the pre-operative brachial index was on average 0.62, but in 12 months 0.87 was significant improvement. When we consider long-term follow-up, we had 4 patients that developed lymph node occlusion midterm at 6 months out to 18 months. 3 required aortic femoral bypass, 1 refused reintervention. 2 of those patients who had SIROPs previously for limited medication were presented with breast pain. And I felt that what might contribute to failure was ongoing tobacco use. 1 patient was just diagnosed with cancer, so I thought he not only did because of smoking, but he also may have been hypercoagulable. This is a case of a 65-year-old female with multiple comorbid factors listed here. Who's had multiple revascularizations for aortoiliac complication disease, presented with left-braided right foot rest pain. She's had many prior interventions for her aortoiliac occlusive disease and continued smoking. You can see here in 1998 she had Palma stents. In 2000 she had bilateral balloon-mounted stents placed over the Palma stents. In 2003 she had more common iliac stents. On the left, she had some self-expanding stents. On the right, the extension of self-expanding stent in the external iliac. And then in 2015, she had occlusive left external iliac artery, which was treated via left brachial artery cut down, and then I was able to cross that and stent that. Except for the 2015 intervention, everything else was performed at a different location. So she presented to me with this heavily calcified aortic and occluded iliac stents with reconstitution of flow and common femoral. They're also quite small. This is her initial aortogram. You can see I felt fortunate to cross, but this is just an X-ray showing you all of the already existing stents that were lining her aorta. This is the completion image after we performed the sterile procedure. And the one required patch that I performed at the end. This is a 71-year-old female with history of cerebrovascular malformation, diabetes, tobacco use, colostomy, paroxysmal fibrillation, and anticoagulation. However, on one of her control angiograms, the interventionalist created an iliac dissection and left her with no flow to left iliac artery. Initially, she was symptomatic, but then it did get worse. Over time, the left brachial index was 0.45 and the right was 0.4. So this is an MRA that they obtained and that we reviewed for intervention. We know that she was at least medical risk and she had colostomy, so we tried to offer an endovascular approach. This intervention was performed. First, I was able to go up the right. I was able to pass up the left. So at that time, I used left brachial access. I was able to body floss out the left femoral artery and then bring up the sheath. I used IRIS to confirm that I was in true lumen. We were able to do the proximal balloon expandable stent here. And then kissing balloon with 5 runs. On the right, I did each to 9, on the left to 7. This is our completion. I post-dilated this up to 8 on the left. This is a case of a 72-year-old female with peripheral vascular disease, tobacco use, COPD, on oxygen, and a prior CDA with right cardiac occlusion, who came in with left foot root-more numbness and rest pain, and she had severe PAD. Here's our CAT scan showing you occlusion, iliac disease, and then very small common femoral arteries measured 4.6 millimeters. Yeah. Again, this is the original angio, not much flow down there, honestly. This is the sterile procedure we performed, and this is our completion. And she's still doing well. So just a couple technical considerations for post-sterile aortic femoral bypass, which I've had to do. I feel the patients who fail sterile or were offered sterile in lieu of aortic femoral bypass are often more medically complex and maybe less compliant with modification of cardiovascular risk factors. The proximity of the proximal stent may necessitate a suprarenal clamping when, if you had done originally an aortic femoral bypass, you may not have needed that. Femoral exposure is often necessary to optimize runoff during the sterile. Now you're going back in that area needs to be reopened and it's a scar growing out, which will cause a longer anesthesia time risk of being injury, which happened in one of my cases. And then additionally, adjunctive medical management after these cases, I've used rivaroxaban in high-risk patients, patients that have small vessels, even though I patch them. The Voyager PhD trial does show that it is helpful in these patients to achieve better vascular outcomes. It can significantly reduce the risk for occlusion, and they did see benefits early, and those continued over time. They saw reductions in unplanned and extended revascularization. And if you only use the Xarelto rivaroxaban with aspirin after 3 months and stop your plaques, they see an acceptable rate of bleeding. Continuation of the plaque showed an increased risk of bleeding. And this is just some data showing without clopidogrel, and they advocate trying to stop the clopidogrel at the 6-month mark. So some conclusions. Data supports superiority of covered stents and task-seeded lesions over bare metal stents. I think I've shown you that there's less satisfactory outcome of kissing stents, and we have made progress here with the CARR procedure. Covered stents can limit complications of rupture, perforation, and embolization. This technique is more widely employed now. And the ultimate goal is to improve patency rates to provide less invasive option for heart patients. And additionally, I think as we continue to develop better stent grafts and imaging, this will be a more widely applied intervention. And the less invasive nature of this procedure may lower our threshold for repair in the higher risk patients who may be intervening earlier. Factors that I feel contribute to lower durability include small femoral vessels, hypercoagulability, continuous valve use, or poor compliance with antiplatelet medication. There's data to support adjunctive use of incineration low dose rivaroxaban, although cost needs to be considered. Continued use of plaque attachment with rivaroxaban may cause increased bleeding, so that needs to be considered. And thank you all for this opportunity.
Thank you. Thank you, Dr. Shaw. Nice talk. Very nice talk. Any questions from the audience? I have a couple of questions or comments. Sure. When I do similar procedures, the stents of choice for me is not balloon expandable. I use the self-expanded stent, influence plot stent, and that tends to do really well for the patient population that I work with. And then in the iliac, I sometimes, depending on the level of occlusion, can get away with express stent. So if it's a small vessel size, still the express stent works in the iliac, and the cover stents are more proximal, common iliac and the distal aorta. That seems to be quite well. Seems to work quite well for me. So I have the VBX, but for some reason I don't use the VBX as much as I use the other stent, just my patient population. One other question I have for you, I know you have patients that do complex surgeries on, and you go post-operatively, like usually you're for bypass operations. And the big issues is post-operatively, I don't know if you have in your institutions, when you do big open surgery, you take them to ICU, and all of a sudden, nurses forget that patients need fluids, and it start maxing patients on presses. Then you have bad things happen. I'm not sure if you have that problem in New York or not, do you?
So first of all, I'm not. So it sounds like you're using potentially a combined covered stents and bare metal stents in your practice, and I don't know any data that shows different outcomes if you use a combined approach. I think that the whole hypothesis of the CEROB configuration is really to prevent knee intimal hyperplasia more proximally. So I think your outcomes should be equally as good. As far as the it's an interesting point that you bring up. It is harder to do an aorta by fem bypass in a patient that has a CEROB in place, and I had to do 2 last year, and it was a little challenging because ordinarily we clamp the aorta for the aorta by fem, and then you do either end to side or end to end, and then you clamp below and you oversew it. Well, now you've got this whole stent in the way. So, what do you do there? So that was a little bit challenging. And then the groins were much more scarred than usual. So that was another complexity of the case. And then I agree with you that we're doing fewer open aortas and fewer aorta bifem bypasses. And although we're sending the patients to the ICU, it's almost like the management that we always did, they're forgetting to do. So we remember that they need aggressive hydration, and we shouldn't be putting pressors on these patients. And, the Frank Starling curve, but we need to remember that the younger generation of trainees and these younger nurses may not be as seasoned, and we have to be aware of that. And I think it's an excellent point that you make. And I've actually noticed that in our institution as well.
One more comment. If you have a patient that you can do a surround, you cannot do one because you can't cross it, and you elect to do an aorta bifemoral bypass, like the picture you've shown, the complete occlusion close to the level of the renals. What are your success rate versus accident bifemoral bypass?
Well, my real preference really is to do an aorta bifemoral bypass unless it's truly contraindicated, because in my hands, axillofemoral bypasses have a lesser patency, at least in my hands. So I think that although it is a much more invasive procedure, and particularly if you have calcium extending up, and if you get in the position that you have to suprarenal clamp to be able to get enough of a purchase to do your anastomosis, that would definitely increase your risks of renal insufficiency or failure. So I think you have to take into consideration, the operator's experience, the patient's comorbid factors, and what are you really trying to achieve, and what is their longevity in these patients as well. So
I agree with you. I have situations where the debate is you give somebody an axillary bypass, knowing fully well these patients are smokers. They're non-compliant. They'll come back in 6 months with infected graft, or they have clotted graft. Then you have more of an issue. I tend, even with complete occlusion to the level of renals, to do what I can to do an endarterectomy at that proximal portion, then do the aorta bifemoral bypass, because I know the patients are going to be a whole lot better.
Yeah, even recently patients who I think, in fact, I have a patient I probably will be scheduling for a SIROB. I refuse to do it, as she's very limited, can barely walk, but she doesn't have any ulcers. And I refuse to do the procedure till she stops smoking. Because in my experience with these two that I had to convert, I don't want to go through that again. I want to force these people to really stop smoking before I put them through such a big procedure. So.
Good. And also one final question, comment per se. What is your experience when you have complex vascular cases and your patients are heavy smokers, and intraoperatively, especially like a FEMPOP bypass, you're having persistent thrombosis, no matter what you do to thrombose? What are your treatment options? Because I have some ideas.
Well, I mean, I think you have to be concerned that someone may have a clotting disorder, right, in the first place, or they're heparin resistant, which is always, you didn't expect it, and now you're sitting there wondering what to do with that problem. Or if you're taking the patient back to the OR, and now you're finding that out. But no, I think thrombosis is a problem, and there's more and more people with underlying thrombotic disorders that are undetected and unconfirmed, and develop. Either we're finding more, or more people are developing them. I'm not sure which comes first. So I'd love to hear your thoughts on how to address that in advance.
I've had several over the years. What I hope to do, if I give massive amount of heparin and they're clot intraoperatively, I don't try. I use 2B3 agents such as Angiomax or Agathroban generously intraoperatively, and even put them postoperatively, and also aggressively use a TPA intraoperatively. That's one way I've been able to avert that problem. Yeah.
Yeah, I've used TPA as well, and I agree with you. I like Argatroban. I've used it a number of times in the Cath lab when we've done cases.
Yeah, but you can use Agathroban and TPA, and that patient population with excellent result. Otherwise, you'd be coming back with another thrombosed graft a few hours later. Yeah, very well. Thank you so much for your talk. We appreciate your assistance with this conference. We hope to see you next year. Thank you so much.
Thank you. Congratulations on your symposium.
Thank you. Okay, very well. Our next speaker will be Dr. Koussayer, Koussayer. He's going to be talking about challenging anatomy in EVAR, and we'll keep the schedule going on after that. Dr. Koussayer comes to us from Saudi Arabia. He is an ex-fellow from the Arizona Heart Institute and currently practices at King's Hospital in Saudi Arabia. Dr. Koussayer.
Good afternoon, everyone. And first of all, I would like really to congratulate Dr.Ourania for putting very nice program for this nice meeting. And unfortunately, I was not able to attend last year and this year, but hopefully in the next year I'll be able to come in person. Today I'm going to speak about how to deal with the challenging anatomy in the EVAR and give you some tips in each step and each challenges we can deal with it during EVAR deployment. All of us would love to have a case like that where the EVAR falls inside the IVU. But real life is different. The EVAR challenges could be at the 4 levels, could be at the neck, could be at the working bifurcations, could be at the distal lateral aortoiliac artery bifurcation, or could be at the axis vessel, which is the external arterial arch. So let's start first with the neck challenges. We have 4 neck challenges. The neck could be short, or could be angulated, conical, or excessive thrombus and calcification. I'm going to talk about every challenge and give you some tips and tricks how to deal with that. So first, let's start with short neck. What the option? If the neck is less than 10 millimeters, then we cannot use any commercial T-bar, and then we have to use an alternative approach like chimney, P-bar, or T-bar. If the neck between 10 to 15 millimeters, then it's better to use an E-bar with a superior fixations. If the neck length more than 15 millimeters, then you can use any E-bar available in the market. What are the tips of the neck 10 millimeters? First, I'm going about the rebounds, because always it's easier to pull the device down than push it up. Don't deploy more than 2 full stents or will not be able to pull the device down. When the stent acts the working wall, pull the delivery system down into positions, do an angiogram to confirm your positions, and then complete your deployment. What is the neck less than 10 millimeters? Which is at that time we're talking about showing our working hand. 2 options. Either we have to increase our ceiling zone by using a chimney or B-bar or P-bar, or the other option is to create an endovascular suture line by using endoambulances. Of course, the best option is to use a B-bar or P-bar, but the problem they have their own limitation. It's a complex procedure. The maximum length should be less than 45. It's a large profile. It has a high renal reintervention rate. It's expensive, and plus the payment takes about only about 2 to 3 months. The indication for chimney graft, if you have an emergency or semi-urgent case, you have a typical renal anatomy where you have a short main renal artery or downward facing renal artery. If you have a graft migration of type 1 emboli and you need an emergency solution, or if you cover renal artery by mistake during the EVAR deployment. What I do for Shiva, the most important, the neck, at least you need a short neck 2 millimeters. You cannot do it if you have no neck at all. And the new ceiling zone should be at least 15 millimeters. The angulation in perineal should be less than 60. Suprarenal neck angulation should be less than 45, and suprarenal angulation should be also less than 45. And the maximum renal angulation should be less than 90. So what is the chimney rules? the new ceiling zone should be at least 15 millimeter. If you use one chimney, the new ceiling zone, we measure it from the proximal aspect of AAA to the highest renal artery. If you use two chimneys, then our new ceiling zone will be measured from the proximal aspect of AAA all the way to the SMA. If you have a three chimney, then you need a longer ceiling zone, at least 25 millimeters. If you're going to use four chimney, then it's better to use a sandwich technique. Oversight is very important. We use a chimney, you need 30% oversight, otherwise you'll end with how we do? First, we get a vascular access, we get a femoral access, then we get a brachial access or auxiliary brachial artery or auxiliary access. Then we target the renal artery or with the Rosen wires. And then we advance a long sheet all the way inside the target vessel. And finally, we attach the cover stent inside the renal artery. We prefer to go from the left brachial auxiliary artery. And usually, if you use one chimney, we use one 9 centimeter French sheet. If you use two chimneys, then we need two 9 centimeter French sheet. Or we can use a large 16 French sheet and put inside the big sheet two 7 French 9 centimeter long sheet. After that, we start EVAR deployment from the femoral axis. We deploy towards EVAR stent. Then we deploy until the contralateral leg is released. Then we finish. Then we release the proximal of the suprarenal fixation to fix it. Then we deploy the distal end of the bifurcated graft, and then we recapture the spindle, and finally we remove the delivery system. After we deploy it, then we start deploying the balloon expandable cover stent. Usually it has to be at least 2 centimeters inside the target vessels, 1 millimeter bigger than target vessels, at least 5 centimeters in length and above the EVAR path. Otherwise, the EVAR will include your chimney. It's very important to not forget to withdraw your sheet before deploying the cover stent. And also the other tips that the distal tip of the transducer sheet should be positioned below the suprarenal anchor skins. Otherwise, the stent can rupture the balloon and you'll be in big troubles. And for deploying the balloon expandable stent, don't forget to reinsert the long sheets inside the target vessel again. And after that, we do the critical limb of the EVAR. Then we do kissing balloon technique. We're very careful when you do that because the device has to move at this time. And then when you move the balloon from the renal artery, it's very important to use the sheet again, because otherwise the anchors of the suprarenal fixation can capture the balloons. So the main problem with the Shiva is like one Emboli, how we can degrade that by hitting the chimney graft, by having a long proximal ceiling zone, by spiraling the cover stent, by using sandwich technique, we use 3 or 4 chimneys. And the question to use balloon of expandable stent is controversial, but in general, if you use electronic, but you use big wall balloon expandable stent, but you use board better, if you use Biobank expandable cover stent, but if you use Biobank, don't forget to put a bare metal stent inside it to give it more stiffness. If you should one of our cases, 31 years old, they present with a large cerebral aneurysm with a 4 millimeter neck. You can see it here, very short neck, and also have a calcified distal aorta, and also has a conical neck. So you have 3 challenges. We are able to treat it with Shiva, with good result, and follow up after 1 year and not like one Emboli. The other option, we have a short neck to use the helix system. It creates stability of the surgical anastomosis in EVAR and PVAR, very similar to the Zichal line. It can be used as prophylactic if you have a hostile neck, you have a short or conical neck, or you have normal anatomy, but patient is a young, I need to give him a good fixation to last for many years. Or patient who have may loss of collapse, so you don't give a good fixation from the beginning. or you can use as a treatment if you have a type 1A emboli as early or late one. Contraindication, you cannot use it if the wall of the aorta away from the fabric of the EVA more than 2 millimeters, or if you have an excessive thrombus, or if you have a porcelain aorta, or if the patient has an ISEVS system. Sure, one of our case will be used as prophylactic. This patient became with thoracic aneurysms. We have a good landing zone, 2 centimeters, but the product when we deploy the device moves backward or distally, and we end with a ceiling only 1 centimeter. Even though it looks no emboli, but 1 centimeter across the aorta, the ceiling is not good, and we knew we can control in the future. So when they are with endo-anchors, we could result and follow up with very stable repair. Another patient who 78 years old became to us with a rupture of an aortic aneurysm. The problem, he has a very short distal landing zone, only 12 millimeters here above the SMA, because we have to cover the celiac artery. And what we did very successfully with the TCAR, but because we have very short landing zone, we put some anchors here to stabilize it. And we got good result with follow up 1 or 2 years without any type 1B legal. Another patient here referred to us because he has a late type 1A emboli. You can see it here. And this is treated very well with endo-anchors with a good result and follow up in 1 and 2 years without any recurrence of his type 1A emboli, 1A emboli. So we talk about the short neck. What about conical neck? By definition, is increased diameter from the top to the bottom of the neck more than 4 millimeters. This increase your type 1A emboli. How would you have a low ratio for placing a Palma stent? And how we size the diameters of the device? We go with the widest diameter, usually at 15 millimeters of the neck. What if we have an extensive thrombus or calcifications? We know that the risk is that can embolize the renal artery, can cause migration, or personal type 1A emboli. All major trials which exclude patients with significant neck thrombus or calcification, but does it have any science behind that? This is a nice paper from the Revascularization Surgery. They look at influence of the neck thrombus on clinical outcome and aneurysm morphology after endovascular aneurysm repair. When they conclude that the presence of aneurysm neck thrombus has no significant influence on short-term and mid-term EVA result. So what the tips, we have an extensive thrombus. First, have the graft and angiogram in place before angiogram. You want the graft starting a little higher and gradually come down while deployment. Get it right at once. You don't want to do too many manipulation in that area because you can increase your embolization in the renal arteries, no ballooning, and increase the wire and catheter manipulations. What if you have an angulated? Well, the solution first, you need an oversize at least 20%, 15% will not be acceptable. Try to adjust your CR, as you can see here. So you need to angulate your C-arm so in the particular renal arteries, you can get the maximum of the length of the neck. Through and through wire to straighten up the neck or you palmas. How we do through and through wire? We go from the bigger artery, we pass the wire all the way to the femoral, then we stir it, and then we put from both sides, from the femoral and the radial side, and this will help us to straighten up the neck and help to advance it. Or you can use a palma stick. The palma stent to straighten up your neck. Like this patient is not like 1 emboli because the angulation is what it is very well with the palma stent. So what that is, remove the stiff wire before the deployment, you get the angulation, because the stiff wire prevents the device from taking the angulations. You got the cup starting higher and go down because it's very hard to push it up when you have severe angulations. Extra DSA, and don't forget to push the wire back. If you remove it to remove that stiffness from the neck. Inexperienced centers, if our severe angulated neck is safe, results are equivalent to match control, no type 1 emboli, migration, stent rupture, no total related mortality were found at 2 weeks. What if you have another aortic complications by deficiencies than 20 millimeters diameters. The problem can cause limb occlusions. What are the solutions? We have a couple of solutions. We can write the classifications by using kissing balloon, but after we got the EVAR, in case of any rupture, we have EVAR to protect it. And sometimes we use further stenting opens, or we can use the work that you need graph and do that actually is an ecologic index that you need a color graph because the main body of the device sit at the aortic bifurcation, only competition, heating, or compression. The solution is for this ingraft sort of a stent graft from the cortex because it has a low profile and there is no ICU for the aortic bifurcation. When I look at the you can use it. It's 1 time down to 11 millimeters. What about aneurysms? Usually it's more than 22 millimeters. You have 3 different options. First, to extend your lining zone, but then you have a problem with the impedance and the other complications. The other option to use the devices. You have 2-1 or 2-1 or you can actually techniques.
That's it.
Or the other one is a bottom technique, but it's a long-term outcome of this kind of the bottom technique and more. What about access result challenges? If you have a narrow femoral artery, go to higher incision. If you have an obese patient, cannot pass the cheese because the artery is too deep, try to perform the skin incision lower than arteriotomy wound, and then pass the delivery system through this to the arteriotomy. What about if you have an iliac calcification, try to go to another iliac artery, can we increase the vessel size by adding sugar dilators? Perform balloon angioplasty to predilate the axis artery or stent any stenosis. And of course, if you cannot do any of above, then use an iliac conduit and use iliac conduit is at least 10 millimeter diagonal branch. If you have a continuous iliac artery, you can use a super stiff wire like lambda quest or ambulant to straight up the iliac artery, or you can put some hand pressure on the down wall to reduce the iliac tortuosity. And the other option is body wire technique or body plus technique through wire, which we talked about it before. What about vascular access complication? The most common complications are thrombosis, occlusion, dissection, perforation, or ruptures. Our management, first don't scare. The most important key is our wire access is your life saving. Not included inclined aorta from the parental axis. Then use a cover stent, but we at least 2 centimeter sealing zone. Don't worry about the internal iliac artery. If you need a good sealing zone. And of course, if you cannot do any of the above, then open emergency open repair is your best choice. So in conclusion, ladies and gentlemen, we see an increased number of patients referred to us with triple A without simple anatomy, but an experienced center triple A with interval anatomy are manageable with EVAR, SHEVAR, or conventional EVAR with active spinal fixation and endo anchors. Available evidence suggests acceptable midterm result. If you have more than one interval anatomy, you have to watch out, and open repair is always an option. And again, for inviting me for your workshop, and if I'm live with you, then I'll be able to take any questions. Thanks.
Thank you, Samer. Are you still there? Okay.
No, he's not there.
Okay. Well, anyway, we'll go ahead and move on to the next speaker, Dr. Funso from Arizona, Prescott, Arizona. And this is Dr. Odunukan, and he's a professional cardiologist, and he'll be talking to us today on a science topic. And after Dr. Funso speaks, Dr. Olsen also is in Arizona. She will be speaking next. Thank you.
Dr. Funso, are you there?
Dr. Olsen? Okay. You're muted.
Did you ask for me now?
No, Funso goes before you, but he's muted, so we can't get him to.
Can you hear me now?
Yes, we can, yes.
Okay,
Yes, we can.
I'm trying to share my
So
slide.
the right beside that mute button is a square with an arrow. That'll open
Yes.
the, yeah.
That's it.
Perfect.
Can you? All right. So let's see.
Thank you.
Well, hello everyone. My name is Funso Odunukan. I'm an interventional cardiologist at Dignity Health in the Yavapai Regional Medical Center at Prescott in Arizona here in the US. And let's see if I could do a slideshow from the beginning. Okay. Can you see my slides?
Yes.
Okay. So this today I'm really talking about acute coronary syndromes, and I think that this is very key because it's a growing concern in Africa. I remember going through 6 years of medical school in Nigeria and never really seeing a classic case of acute myocardial infarction. And fast forward, 12 years going back home and realizing that it has become an issue. And I'm not sure that it was never there. It probably was that it was just being underdiagnosed. So that's just a little bit about me. I do minimally invasive vascular, valvular, and complex coronary work, trained at the University of Ibadan in Nigeria, and my fellowship training was done at Mayo Clinic in Rochester and in Jacksonville, and I did interventional cardiology at Scripps Clinic in La Jolla, California. I have no relevant disclosures. Today we'll be reviewing the different types of acute myocardial infarction, differentiating between STEMI and non-STEMI. We'll talk about how to triage patients to the Cath lab. We'll discuss antiplatelet and antithrombin selections, as well as medications to use after treatment of acute coronary syndromes. We'll also touch briefly about the common complications. Acute coronary syndromes is that constellation of unique conditions that center around coronary arterial thrombosis and may lead to sudden death. They comprise unstable angina, non-ST elevation myocardial infarction, and the ST elevation myocardial infarction. And they actually are interwoven and can evolve. For example, a patient can start out with unstable angina and then develop abnormal EKG findings with positive biomarkers. And also that could eventually evolve into ST elevation myocardial infarction, popularly called STEMI. And patients can have each of these conditions too individually. Before we go on, I think it's important to review the types of myocardial infarction. You have type 1, which centers around spontaneous plaque rupture, ultimately leading to an intraluminal thrombus that would result in cessation of myocardial blood flow, resulting in acute myocardial necrosis. That spans the most common types of acute coronary syndromes that we see. However, type 2 MI is also important because it results in myocardial injury, and it's essentially as a result of a mismatch between myocardial oxygen demand and myocardial blood flow. And it occurs in the absence of acute plaque rupture or coronary thrombosis. The other types of myocardial infarctions are related to either sudden cardiac death, as is the case in type 3, or periprocedural, type 4 for PCI and type 5 in CABG. And so the criteria involve the use of biomarkers with any of symptoms of myocardial ischemia, your classic symptoms being chest pain or shortness of breath or the like, or EKG abnormalities, or findings of suggestive of loss of viable myocardium on imaging, for example, regional wall motion abnormalities on echo that were not present prior. So in type 1 acute myocardial injury, they're broken down into categories, as we talked about, ST elevation ACS and non-ST elevation ACS. And in non-ST elevation ACS can either be non-STEMIs, where you have biomarkers or EKG abnormalities, or unstable angina, where none of this is present. So for type 2 myocardial injury, it's mostly because of demand angina, as we talked about. However, we have to acknowledge that some patients may have underlying coronary artery disease, but for the most part, it's as a result of high myocardial workload And in some cases, you could have vasospastic angina that may be drug-related, for example, in the use of recreational drugs like cocaine. Sometimes it's idiopathic, like you have in the premenstrual angina. And lately, we've started to have, the microvascular disease or the MINOCA, myocardial infarction with normal coronary arteries. So it's important, in acute coronary syndromes, the history is critical. A patient typically comes in with classic symptoms of chest heaviness or tightness that may or may not radiate down the left arm or into the neck or jaw. And these symptoms may be associated with dyspnea or shortness of breath or diaphoresis. So, and in women, symptoms can be atypical. So in that case, all they may give you may just be nausea, a feeling of being unwell. And you also have to ensure that these symptoms are not suggestive of other pathology. For example, if the chest pain is pleuritic, it may suggest a mimic like pericarditis. So tearing chest pain may suggest a different differential, for example, a dissecting aortic aneurysm. A quick physical exam is necessary, and things to look out for are things that may point to alternative diagnosis. Things like tachycardia, atrial fibrillation, respiratory distress may suggest heart failure or PE. Fever may suggest a patient that's septic. The EKG is critical, and it's important that we always interpret this in the context of clinical presentation. In this age and time, it's not uncommon for us to be walking backwards. We find an incidental finding on EKG and trying to fit the patient to the EKG instead of starting from the patient and going on to workup. It's also important to note that a normal EKG does not exclude acute coronary syndrome. So if you have a patient who's giving you classic symptoms, but the EKG is normal, that may just be unstable angina. Now, when we look at the ECGs, ST elevation is highly specific, and that's enough to trigger the systems for immediate action. ST depression is moderately specific. On the other hand, T-wave inversions are poorly specific. And as pointed out, 10% of ACS cases can have normal EKGs. So what's the role of cardiac biomarkers in ACS? They're highly specific and sensitive for myocardial ischemia and injury. However, in the right context, one has to put things together in order to be able to confirm acute MI. It's important to note that it does not distinguish between type 1 and type 2 injury. So with acute coronary syndromes, in 2014, over 2 million US hospital admissions were for ACS. Over a quarter of those were for ST elevation myocardial infarction. More than half of those were non-STEMIs, and the remaining proportion of that was made by unstable angina. So these are examples of the different kinds of ST elevation myocardial infarctions that we can have. Over at the top left is that associated with the LAD, so giving you an anteroapical infarct. And to the top right is you have ST elevation in the inferior leads, and that actually could also be caused by dominant left circumflex. And the others are also examples of injuries associated with occlusion of the right coronary artery. So in specifically focusing on STEMI now, this is usually as a result of an acute total or subtotal coronary occlusion. It will result in ongoing myocardial injury and infarction. There's a high risk of ventricular fibrillation and sudden cardiac death if no reperfusion is done immediately. Management is usually aimed at chemical or mechanical reperfusion. So here's the algorithm for reperfusion therapy for patients with STEMI. A patient who comes in with acute myocardial infarction and ST elevation on EKG, action depends on where that patient is seen. If that patient is seen initially at a non-PCI capable hospital, then the recommendation is to administer fibrinolytics within 30 minutes of arrival. When anticipated first medical contact to device time is greater than 120 minutes. And those patients, if reperfusion fails, they should be transferred urgently. But if symptoms resolved, then those patients still within 3 to 24 hours need to be transferred for PCI as part of the pharmacoinvasive strategy. For patients who can, within 120 minutes, they should be transferred to a PCI capable facility. And to the left of the algorithm, you see if that patient is seen at the PCI-capable hospital, then the STEMI systems are activated, and that patient is taken to the Cath lab with the goal of ensuring reperfusion with the first medical contact to device time, or popularly called door to balloon time, of less than 90 minutes. Now, based on the diagnostic angiogram, then that determines what's done. For majority of patients, primary PCI is enough for reperfusion. But other patients, who, especially those who have multivessel disease or may have LV dysfunction, bypass surgery may be an option. And for patients, especially those who are presenting late, medical therapy may be the optimum strategy for those patients. And so for patients, primary PCI is favored over thrombolytics. But in this talk, I want to spend some time talk about the role of thrombolytics, because in emerging economies and countries without highly developed STEMI facilities or PCI-capable hospitals, as is the case in Nigeria. I think that in Nigeria, if you could count, I doubt that there are less. We have 10 PCI-capable hospitals in the country. So I think that it's important to know what the other options are. Chemical reperfusion using lytics is still a feasible strategy. So patients, if primary PCI is not possible within 2 hours, then lytics are favored. When possible, those patients should be sent for salvage PCI in what's called a pharmacoinvasive strategy. So thrombolytic reperfusion therapy was the first form of reperfusion therapy